Balaji sir,
Yes,
we
madam.
had a nice public forum on the installation.
Okay.
Yeah.
You are doing
What
excellent work,
performance?
madam. Huh?
Thank you, sir.
What performance is it?
It was a big forum.
Sorry, what
All
is it?
about anesthesia. It's to amongst people about subject.
Your voice is not clear.
About anesthesia. Sir, now am I audible?
Yeah.
Better.
She is the president of Nagpur ISA city branch.
Oh,
Hello, am I audible now?
Yes,
yes,
madam.
yes, very much.
Ma'am, there's little problem with the network.
Yeah, that's what I'm trying to figure out actually.
Yes, little bit. Just
I can switch on the hotspot. I'll just see.
yeah. Wi-Fi will be good.
Now is it better?
Yeah, it's better.
Yes, ma'am. Better.
And actually, sir, that moment was really special when we got opportunity to address more than 20,000 people. We got a platform to give demo to 20,000 people at Khasdar Sanskritik Mahotsav that is held every year in Nagpur.
My goodness.
So we demonstrated, we told them about anesthesiologists, their role in the society. We demonstrated coals, and it was an excellent program and an amazing experience.
Really?
That's really great, madam.
Very nice.
Very
nice.
Thank you,
so
sir.
Nagpur is going to be on the world map now.
It is already, sir. Nagpur is first branch at all India level. Such an active ISA branch.
ISA,
yes.
That's great.
So, sir, we have won many awards at that national and state level. ISA Nagpur. So as madam said that
on public awareness this year.
Yes.
And in fact,
so
we
again,
have a special social commitment also this year. Mission No Tobacco for Safe Anesthesia. So we will be going to the colleges, the schools, and we'll create awareness about the ill effects of tobacco and how it affects the anesthesia outcome when the patient comes with the complications. So this is our special social commitment.
And as madam said, on the day of installation, we had a public forum where questions about to know what is anesthesia and anesthesiologists were answered to the common public. And they really, one representative from the lawyer committee, she was really very happy that we have kept such a program and we are answering their questions and queries. So she was so impressed that we really want that the anesthesia people should come forward and really tell what exactly anesthesia is. Yeah, and so we did that thing. I think madam will add to that. Sorry, madam.
Yes, actually, she had the idea that we anesthesiologists, we go inside the OT, we anesthetize the patient, and we go out. And at the end of the surgery, we come back to the OT and we awake the patient. She had this kind of an impression. Like
misconception.
she was not able to believe that throughout the surgery, we are there to monitor the patient.
Absolutely.
So they had this so many misconceptions.
Correct.
Dilip sir, I'm audible to you?
Hello.
Dilip sir, I'm audible
Yes,
to you?
yes, madam, you're audible and visible to us.
Okay, thank you.
Yes, Vishali, madam.
I can see my
You're
slide
audible
also.
to everybody, and we can. Yes,
Okay.
we can see
Okay,
our
only 10
flyer
minutes
on
left
the
to start.
screen.
5 minutes, I think.
Can we check
I think
whether
there are
we can share?
7 minutes.
6 minutes to
We'll start up.
Balaji sir,
Yes, sir.
something,
Please, you
sir?
can.
Share screen, I will just want.
Charu hai Allah. Should I stop sharing my?
Nilesh.
Yeah, I
Yes,
think
yes, madam.
Stop sharing, then sir.
Then
can
sir
share.
will share.
Okay, should I stop?
yes,
Good
yes.
evening, everyone.
Good evening, sir.
Now,
Hello,
sir, you
Nilesh.
slide.
Yeah, hi Balaji, how are you?
Fine. How are you?
Fine.
Good evening, sir.
Nilesh sir, welcome to the webinar. Good evening.
Yeah,
Murli,
good
Welcome,
evening,
Balaji
good
sir.
evening.
welcome Rahul sir, welcome Nilesh sir, welcome
Rahul sir.
Balaji sir. Good evening to
Thank you.
everyone.
Thank you.
Hello, good evening to all. I am
Uh,
Dr. Rahul from Akola.
Yes,
yes.
sir.
Good evening.
Welcome,
Oh,
sir.
Your panel is
Arey,
for
welcome. Welcome, sir.
Welcome, Dilip sir.
Balaji sir, can you share your screen?
Yes, I'm sharing. Yes. Is it visible?
yes,
Yeah, your
yes,
screen,
sir.
many presentations are visible.
No, but now
No,
Sir.
from my end, it is presentation has started already. Huh?
no, sir. There must be some lag. We'll wait for 30 seconds, or you can again unshare and again share the screen.
Okay. 1 second.
Yes, sir. Now it is visible.
Now it's visible, sir.
Yeah, it's in slide sharing format.
Yes, sir.
Thank you. Now I'm moving the slides.
Yes, slides are moving,
Okay.
sir.
Yes. Thank you very much. Now I will stop sharing.
Yes, sir.
Should I try mine? Whether mine is getting
Yes.
shared quickly?
Yes, sir. Please, sir.
Yeah. So I'll just start share.
Yes, sir.
This. Can you see this?
Yes.
Yes, sir. You can put it on slide share.
Slide share. Just wait on slide share. New share, is it that?
No, it means just
Sir, play
slide
button,
show.
play button.
Play
Slideshow.
button.
Okay.
Play button.
Just see this.
Yes.
Yes,
Is it
sir.
okay?
Yes, sir. Can you go to next slide?
And now
Yes.
yeah,
Yes,
this is my
sir.
next
Yes,
slide.
sir. Yes, sir. Introduction
Okay, great.
visible. No problem.
Yeah. Okay, great. So I'll
Thank you,
again
sir.
stop sharing.
Yeah, you can.
So
Yeah,
stop
stop your screen. Yeah.
Great. Yeah.
The registration for the webinar we have opened, and we have the registration was closed at 100. We have 100
oh,
registration for the webinar.
huh.
So for other participants, we have opened the YouTube link and we have circulated the YouTube link also for this webinar.
Okay.
Hello,
Murli. Good evening.
Namaste.
Good evening, Deshpande sir.
Yeah, good evening, Nilesh. काय म्हणता?
Where is
First class
Deshpande?
चालू आहे, sir.
Yeah. Hello, Rahul. काय म्हणतो अकोला?
Sir, good evening.
Good evening,
SK sir.
Gauri.
Good evening, sir.
Hello, sir.
Balaji.
Good evening, sir.
SK
Deshpande sir, good
and
evening.
welcome.
Good evening, Rahul.
Oh, sir.
Fine.
Deshpande sir, good evening and welcome.
Thank you.
So I think we have 2 minutes to go. Vrishali madam.
Should we start, sir, now?
We will start after 2 minutes, madam.
2 minutes. Okay.
Yeah.
Vinay has
Let the
joined.
participants join
Yes, sir, I'm here, sir.
meeting.
Vinay has joined.
Yes, sir, I'm here.
Okay. Good evening, Vinay.
Good evening, sir.
Good evening, Vinay.
Hi, good evening, Rahul. What is the time limit? Like, when is the web going to go off?
Ganesh. Hello.
How much time do we
Technical.
have?
हाँ गणेश टाइम लिमिट कितना है मीटिंग का
3 hours.
Okay.
3 hours. Okay. Thank you.
Thank you. Actually, Dr. Sandeep Diwan probably is busy in a case. He messaged me that he will probably may or may not be able to join. So let's see how it goes.
Fine, sir. Yeah. Also visible on the YouTube link. I've started link to check it. It is also visible on YouTube.
Past 6:30. Should we start?
Yes.
Yes, we can start.
Good evening and warm welcome to all my seniors. The cardiac patient, when it comes for a non-cardiac surgery, it is always very stressful situation for all the anesthetists. If many times the experience also doesn't matter. So ISA NCB has planned this webinar to simplify this cardiac anesthesia for cardiac patients. And so I welcome everyone. The topic of today's webinar is simplification of cardiac equation for non-cardiac surgery. With all due respect, now I would like to call Dr. Gauri Arora, ISA NCB President, for her welcome speech.
All the respected dignitaries, Dr. Balaji Asegaonkar, President SAMS, Dr. Rajesh Tagarpalle, Honorary Secretary SAMS, Office Bearer of SAMS, GC, all the GC members, Dr. Sheetal Dalal and Dr. Manisha Shembekar, GC members of SAMS from Nagpur City Branch, respected faculties, all senior members and colleagues. A very good evening to all of you, and I welcome you all to today's CME. There is an increasing number of cardiac patients undergoing non-cardiac surgery, and we face many dilemmas while giving anesthesia to them. Which anesthesia to give, which drugs to use, can we give regional anesthesia, when to stop the anticoagulants, how to explain the risk, how to counsel the patients, and there are n number of questions. So let us get the answers from of our dilemmas from our expert and eminent faculties. So I welcome our faculties, Dr. Balaji sir, Dr. Nilesh Juvekar sir, Dr. S.K. Deshpande sir, Dr. Shrikant Bobre sir, Dr. Sandeep Diwan sir, maybe he'll join later, Dr. Rahul Pingre sir. We are privileged to have respected Dr. K. Muralidhar sir as an expert for today's CME, who will enlighten us on various aspects of this topic with the knowledge so that we manage the cardiac patients in a better way. Thank you, sir, for accepting our invitation.
Thank you. Thank you for the invitation.
Thank you, sir. I welcome the moderator of the panel discussion, Dr. Vinay Kulkarni. In fact, this is his concept, and I proudly say that he is a member of ISA Nagpur City Branch. Welcome, Dr. Vrishali. She is the academic wing head of Nagpur ISA. Once again, I welcome all of you to today's CME, Simplify the Cardiac Equation for the Non-Cardiac Surgery. So I hand over the proceedings to the coordinator.
For your warm welcome speech. Now we will like to begin our session. Before we begin for today's webinar, I would like to give some instructions to the participants that please put your phones off and put all questions in a chat box. Discussion and answer session will be taken after the 2 lectures. So here we begin our webinar. Now I request Dr. Balaji Asegaonkar for his presentation. Good evening, sir.
Good evening, madam.
Just wait a minute. I'll just share CV. Dr. Balaji Asegaonkar doesn't need any introduction. He is currently president of SAMS. He is director of Ozone Anesthesia Group, and his present affiliation is director of Ozone Anesthesia. He is expert in echo and faculty of echo teaching also. So we are very happy to have you, sir, here for the webinar. Now I hand over the session to you, sir. And I'm stopping sharing my. Sir, please share your screen.
Yes. Good evening to all. Thank you, madam, for your kind words for me. Respected Gauri madam, president of Nagpur ISA, Dr. Dilip, and so many my friends from Nagpur, Deshpande sir, Shital Dalal madam, Manisha Shembekar madam, or GC for SAMS. I always praise Nagpur branch because it is one of the most active branch of Maharashtra state, and it's really pride for me as a president to be always associated with your branch by one way or the other. And I congratulate madam for, as she has been recently installed for as a president of Nagpur ISA, and secretary Dr. Dilip for assuming the office. And I wish them best luck and full support from Society of Anesthesiologists Maharashtra.
Thank you very much, sir.
Yes. Now you have kept a very interesting webinar, and the topic you requested me to talk on interpretation of echocardiography report. So maybe next 20 to 25 minutes, I will try to give justice to this topic. Echo report. Nowadays, it was very difficult to get echo in our previous days when we were working as a resident. But nowadays, invariably, at least in cities or in big hospitals, echo reports is invariably there for the patients who has posted for non-cardiac surgery. Echo is a very simple as such test. With transducer we kept on patient's heart and all the anatomical information we tried to gather, and in this format that report is given. But as an anesthesiologist, as a non-cardiac anesthesiologist, most of the time, everyone is concentrated on how much is the ejection fraction. Even surgeon, even those who are assistant surgeon, even most of the time physicians, everyone concentrate around how much is the ejection fraction. And everything, if ejection fraction is normal, everyone says that patient is very low risk. But this is not actual the fact. And when we have got such a huge information from echocardiography report, why not to interpret it in a better way? And why not to see what are the useful things that as an anesthesiologist I must see in the echo report. Now, what is we aim at? Suppose I have shown you this side of FedEx and I ask you, where is the arrow in this FedEx? So probably it is difficult for to find out that arrow. But if I show you this arrow in this FedEx, it is a courier company and it is represented by this arrow. When you know this, it is a sign. Sight is what you see with your eyes, but vision is what you see with your mind. And that mind we require whenever we want to see the echo report in detail. And I'm going to talk about that. So my aim of presentation is how to comprehend the complete echo report. What can be the red flags, or what are the things that direct us or that tells us as an anesthesiologist about the severity of the heart condition. And as an anesthesiologist, I am not a physician, I am not a cardiologist. I may not know minute details of this, but as an anesthesiologist, can I correlate few of those things for my decision making during perioperative period? What are the relevance of those findings? And is there any those findings that we can overlook on echo that I'm going to talk in our subsequent slides? Now, echo can be done in two ways. One is a transthoracic echo, and as a cardiac anesthesiologist, we are doing a transesophageal echo. Transesophageal echo, we put a probe in the esophagus and it goes exactly on the back of the heart. It gives a very crystal clear image, but the problem is it is a bit invasive. Patient usually is under general anesthesia. It's like doing a endoscopy of the patient. So it's not very routinely done. On the contrary, transthoracic echo is very safe. It can be done rapidly. It can be done multiple times, even before anesthesia. But the problem is that it requires some or the other kind of expertise. And there are many problems about acquiring the image, or if there are problems with the patient, then we may not get the good image that I will try to discuss in next slide. So the limitations of transthoracic echo is if patient has got a very obese patient has got an emphysema, patient has got on mechanical ventilation, his lungs are getting ventilated too much, or maybe there are poor quality images. So even if we get report, we may not acquire that good quality images, and all that echo reports or reporting is depend on the what are the quality echo you are getting on the machine. So there are inherent limitations to echocardiography, transthoracic echocardiography that we must know. Secondly, does echo reveal everything about the heart? No. Many dynamic heart conditions echo cannot reveal. Maybe at rest, some patient might be having a very severe coronary artery disease, but at rest he might be a normal. So at resting or in normal conditions, his echo might be a perfectly normal. Or let us take the example of dynamic heart obstruction. In dynamic heart obstruction, at normal, when patient heart is not subject to state, there is no obstruction. Or even valvular stenosis, valvular regurgitation, they behave differently when their heart is subjected to a stress. So it doesn't mean that echo is normal means everything is normal. If you see, this is a normal, more or less normal echo, ejection fraction is 57% and no regional wall motion abnormality. But patient was having a classical symptoms of IHD. And when angiography done, there was a critical narrowing in the left main artery. So echo definitely reveals good things about the heart, but it also can conceal so many things that as an anesthesiologist, we must know. As an anesthesiologist, this fact must be explained to the surgeon, to the relatives. Otherwise, as echo is normal, everyone is thinking that patient's heart is normal and there will be a good outcome. And something goes wrong, that may backfire on us. So it is very important to understand that echo can conceal a few things. Now, when you do echo, what information echo tells us? Echo tells about chamber dimensions, how much is ejection fraction, how is signs of whether there is a pressure volume overload or volume overload to that chamber. Then it tells about valvular pathologies like stenosis, regurgitation, prolapse. As far as aorta, it can tell us about dilatation, dissections, and also many things echo tells us. Now we will try to analyze what are the things commonly echo tells us and what, as an anesthesiologist, how I could benefit from them. First and foremost things about the ejection fraction. Ejection fraction is nothing but the amount of blood that is ejected out from a heart with each beat, and it's given by a formula end diastolic volume divided by end systolic volume divided by end diastolic volume. Suppose 100 ml of blood is in left ventricle and 70 ml is ejected with each contraction, roughly ejection fraction is 70%. When ejection fraction is reduced, naturally less blood is ejected and more blood remain in the LV. And it is calculated with so many methods, maybe by M mode, maybe by eyeballing, or maybe by actually calculating the dimensions and calculating, putting it in a formula. Machines usually put it and give us a ready-made answers for the ejection fractions. Now, limitations of ejection fractions, many times there will be a presence of regional wall motion abnormality in one area. You put the M mode beam on a normal area and you may find that this ejection fraction calculation might be a normal. Visual confirmation, there can be a bias if operator is not very proficient with doing the echo, if operator is not very used to do the echo, there can be eyeballing can be problematic. With other methods also there can be a problem. So on cross level, it will invariably tell that normal ejection fraction, maybe their reporting will be normal, but at times there will be limitations for ejection fractions calculation. Is normal EF means patient is normal? Absolutely not. We have to see so many other factors which are already been shown in the reports. And one of those factor is diastolic function. Many times on echocardiography, only it is written there is a diastolic dysfunction and that grading has not been done. But if you see diastolic dysfunction means heart is non-compliant to the fluid. Heart is not relaxing. So whenever excess fluid will be there, heart can go in a failure. So it is like a filling problem. Systolic heart function is a pumping problem, while diastolic heart function is a filling problem. And it is categorized. I will not go in details how it is categorized in grade 1, grade 2, grade 3. But grade 2, grade 3 diastolic dysfunction, they are very dangerous conditions that can give us a lot of problem. In spite of there is one entity, ejection heart failure with preserved ejection fraction. All these are the diastolic dysfunction which are causing signs and symptoms of heart failure. And in these patients, even though systolic function is normal, we cannot conclude that this patient is normal. We have to find out we have to evaluate his diastolic dysfunction. As a non-cardiac anesthetist, how I should proceed? Suppose it has been written on echo, there is a presence of diastolic dysfunction. As a non-cardiac anesthetist, I don't know much how I should proceed or how I should approach the patient. The answer to this question is always evaluate patient. Even though there is a diastolic dysfunction written in echo, you must evaluate the patient clinically. How is his effort tolerance? Can he walk 2 flights? Can he walk for 6 minutes walk test? Do he have any signs of failure? How much is baseline saturation? Baseline saturation 92 and baseline saturation 99. So there is a lot of difference between that. So one has to clinically evaluate the patient when there is a entity like diastolic dysfunction mentioned on the echo. If patient has got a normal exercise tolerance and diastolic dysfunction written on his patient, maybe have a early stages of diastolic dysfunction and you may not have to do too many things. But if it is a severe stage, patient has got a symptomatic breathlessness and patient might have a signs and symptoms of congestive cardiac failure. This patient can be in a diastolic heart failure. I will give you one example. A 55-year-old female, obese, hypertensive, diabetic since 5 years, posted for laparoscopic hysterectomy. Patient was having a very poor effort tolerance. All lab reports were normal. Even echo was normal with just diastolic dysfunction mentioned in the echo. But clinically, when I saw this patient was having a bilateral edema feed, basal crepes, her heart rate was 100, BP was 160, 100, and saturation was 92 on room air. This is not a good sign. When we have seen the X-ray of this patient, there was a huge pulmonary congestion and patient was in a diastolic heart failure. So we immediately postponed the case and patient was put on diuretics and rate control drugs, and subsequently after 8 days when patient optimized, we done that case uneventfully. So as an anesthesiologist, we must keep we must get alert whenever such situation such things is mentioned and echo, and always clinically try to correlate the things. So systolic failure is usually it is pump failure, as I already stated, but in diastolic patient cannot be filled. You given a 400 ml of volume, 500 ml of bolus of volume to a patient with diastolic dysfunction, and suddenly patient land in a pulmonary edema. This so many times, and everyone is discussing echo report to normal tha. It's not like that. So we must concern about the diastolic dysfunction. On echo, many times this is mentioned about the chamber hypertrophy. Whenever you see echo report mentioning chamber hypertrophy, you must think in a way that there can be a presence of diastolic dysfunction. Heart is not relaxing because there is a huge chamber hypertrophy. So you must analyze the echo in the context of the patient, and whenever you see the echo report like this, you must again go and try to see the patient and try to find out the cause. For example, one is if there is a hypertrophy, if there is a chamber hypertrophy. Many times there will be unequal chamber hypertrophy, and septum might be hypertrophied more, and patient might be suffering from a HOCM, hypertrophic obstructive cardiomyopathy. It is nothing but the septum hypertrophy to the extent, and there is increased systolic anterior motion of the mitral valve that is causing an obstruction for the LV outlet tract. And if you give inotropes to this patient, if there is a sudden increase in heart rate, this obstruction might increase, and patient, there are so many cases of sudden death in HOCM patient. So you have to be extremely cautious when you see echo report with HOCM, or when you see echo report with such a huge septum shown shown to you. Now, there are multiple examples on echo, multiple patients who has got a cardiomyopathy, like dilated cardiomyopathy, or obstructive cardiomyopathy, or hypertrophic cardiomyopathy, or restrictive type of cardiomyopathy. Whenever these are mentioned in the echo, your decision is changed. Your decision regarding managing this patient during anesthesia, during perioperative period is changed. So you must watchful to see these reports and act accordingly. For dilated cardiomyopathy, heart is dilated, and a reason might be ischemic valvular. We are not going to. In hypertrophic cardiomyopathy, there will be hypertrophy of the ventricle. In restrictive cardiomyopathy, it is more or less like a diastolic dysfunction. Heart is non-compliant for the fluids, and these are very commonly encountered. Now, left atrial enlargement. LA size is invariably mentioned in the echo reports. Now, let me tell you, if LA size is more than 45 or 44, invariably these patients land into atrial fibrillation during the perioperative period. All echo reports shows us about the LA enlargement. And suppose you are evaluating the patient and you see that there is a LA slide is much bigger in this patients, then and if you are going to anesthetize patient, you should be mentally prepared. You should be prepared with all instrument, maybe defibrillator, maybe antiarrhythmic drugs inside the OT, that this patient can land into a atrial fibrillation. And if LA size is increased more than 44, more than 48, invariably these patients land into atrial fibrillation during the perioperative period. And suppose this patient has got aortic stenosis, so this patient has got a ischemic heart disease, who are depend on their cardiac output is depend on atrial kick, and suddenly this atrial kick goes, this patient suddenly goes in a hypotension, this patient suddenly goes in a failure. So if you mentally prepare, if you prepare with yourself with the instrument, your inside antiarrhythmics, and you can predict these things when you read the echo report in details. Similarly, about pulmonary hypertension. So many times we see echo report with mentioning that there is evidence of pulmonary hypertension. Now, as an anesthesiologist, what I should do when I see the report? For that, you need to know the classification of pulmonary hypertension. Pulmonary hypertension now classified in a 5 group as per it's the cause of pulmonary hypertension. For example, in class 1 or group 1, it is a primary pulmonary hypertension where we don't know the cause. In group 2, it is cardiac cause that is causing a pulmonary hypertension. Group 3, it is a lung cause that is causing a pulmonary hypertension. Group 4, chronic thromboembolic phenomena that is causing a pulmonary hypertension. And group 5 may be sarcoidosis or maybe autoimmune diseases that are causing the pulmonary. Now, as an anesthesiologist, why I should know that? The answer is, suppose you know that pulmonary hypertension has caused by the lung condition. Once you know that, you can optimize this patient before you post this patient for a surgery or a stress of anesthesia, stress of surgery. Simply increasing their nebulization, their decreasing spasm, their decreasing the element of COPD helps this patient preoperatively to face the surgery anesthesia in a better way. If you see the signs, pulmonary hypertension is caused by heart condition. There is overflow, there is a volume overload, or there is a pressure overload. You can take some measures which will decrease that volume overload, and ultimately there will be a decrease in the pulmonary hypertension before you post this patient for a surgery. So knowing this is very, very important preoperatively. And if you see in echocardiography, there is evidence of pulmonary hypertension. Always try to find out what is the cause for that pulmonary hypertension. Now, regional wall motion abnormality. So many times it has been mentioned, anterior wall hypokinesia, anterior wall akinesia, dyskinesia. What do you mean by hypokinesia? Means wall is not contracting at its best. Means normal contraction, it is contracting less than normal contraction. Akinesia means it is not contracting at all. It is like a scar tissue formation. Post-EMI condition might be there. And dyskinesia means on contraction, rather than contraction, it is bulging out. This is a very dangerous condition. When dyskinesia present, it is a very alarming for anesthesiologist because it can create a lot of complication during a perioperative period. As an anesthesiologist, why I should know which wall is hypokinetic or which wall is dyskinetic? I will give you one example. These are the two patients posted for the same surgery, lap hysterectomy and lap hysterectomy. More or less, the patient profile is same. 52-year diabetic, IHD, post-MI, ejection fraction around 35%. While in second patient, 54-year hypertensive diabetes, ejection fraction 44%. But the difference is that on one side, echo anterolateral hypokinesia, and in another case, it is infero-posterior hypokinesia. Let me tell you, most of the LV is anterolateral wall. And when anterolateral wall is not functioning to its best, these patients can easily land up in LVF during perioperative. On the contrary, those patients who are suffering from infero-posterior hypokinesia, they may be better tolerant to the fluid. Rather, we have to keep their preload at optimum conditions. And these patients are likely to go, they are less likely to go in failure, but more chances of arrhythmia, more chances of hypotension due to non-proper optimization of preload is very common. So as an anesthesiologist, we must see which wall of the LV, which wall of the heart is affected, and that is really helpful when you are doing a non-cardiac surgery. So detailed echocardiography report must be seen in the context of the patients. Now, valvular stenosis, most of the time, echo reports mention it is a mild, moderate, or severe valvular stenosis. But as an anesthesiologist, we must see how much is the pressure gradient. Pressure gradient is nothing but a difference between the aortic pressure and the left ventricular pressure. Suppose there is one patient who has got a pressure gradient of 80 or 100. There are so many patients who comes with pressure gradient of 80, 100 for aortic stenosis. It means that if his systolic blood pressure is 120, the pressure within the LV cavity is 220. Now this patient goes in a hypotension during surgery, and this LV pressure suddenly deteriorates. That can patient land in so many problems during perioperative period. So we cannot allow have a sudden hypotension in these patients. That is why, as an anesthesiologist, if you know these facts, you can deal with these cases in a better way. That is why you must see just how much is the gradient across. In mitral stenosis cases, most of the time we concentrate only on mitral wall area. But we must always try to see how much is the pressure gradient. Is there associated pulmonary arteries hypertension has occurring? And it helps a lot when you are managing such cases during the perioperative period. Similarly, wall regurgitation, just it is mentioned, mild, moderate, or severe regurgitation. But how, as an anesthesiologist, at least we should have some idea how this regurgitation categorized in mild, moderate, or severe. Roughly, when this regurgitation volume is more than 50%, more than 60% of the LV volume, we categorize it in a severe form of regurgitation. Or we can't calculate this diameter of base diameter of this jet. More the diameter, more will be the severity. What we call it as a vena contracta. And whenever there is a severe regurgitation, our whole management or the approach towards the patient changes. Many times, another important fact, as an anesthesiologist, we must know that in presence of regurgitation, ejection fraction calculation is wrong, or it is whatever ejection fraction shown is invariably overestimated. Why this is happening? Because suppose there is a regurgitant lesion and LV contracts. Now part of blood going into the aorta and part of blood going into the LA. So at the end of diastole, there will be more blood into the LV, and at the end of systole, less blood into the LV. So there will be a more difference between end diastolic volume minus end systolic volume due to this regurgitant leak, which is overestimating the ejection fraction. One patient who has got a 30% EF with moderate to severe MR, probably EF may be less than that. EF may be 20%, 25%. So EF calculation is totally overestimated in this patient. So as an anesthesiologist, we must know this fact. We get few patients who has got a prosthetic heart wall replaced. Now it is just mentioned prosthetic, but as an anesthesiologist, you must see how the wall is functioning. Is this leaflets are functioning to its optimal? Might be one leaflet is opening, might be other leaflet is not opening. How is the functional status of the wall? Is there presence of paravalvular leak? If there is a presence of paravalvular leak, it's like a MR-like condition, regurgitant-like condition. Is there a presence of vegetation? What anesthesiologist will help, how it helps agitation in perioperative monitoring? If there are vegetation, you can explain the risk of stroke to the patient's relative. You can explain the risk of stroke to the surgeon. Whenever there are vegetations that may get dislodged during the stress of anesthesia, during sudden tachycardia, sudden stress to the heart. So we must look towards these points. Congenital heart disease, I will not go in details, but it is invariably mentioned about ASD, VSD, PDA, right to left shunt, left to right shunt. But as an anesthesiologist, I don't want too much information about this thing as a non-cardiac anesthesiologist. But at least I should know what are the severity of what are the things that are written that may indicate the congenital heart disease is severe, and what are those things. Right to left shunt instead of left to right is invariably means there is a mixing of blood, there is a cyanosis, there is a mixing, and deoxygenated blood is circulating into the body. Whenever the larger the defect, more is the severity. Whenever echo mentioned the very large VSD, it is a severe form of disease, and this is very high risk patient. Presence of moderate to severe pulmonary hypertension. These are the severe coronary congenital heart disease. Complex congenital lesions. Again, it goes in a severity of congenital heart disease. And all this is mentioned in the echo. Just one has to look into it. Other important data usually echo gives about pericardial diseases, maybe pericardial effusion, Then infective endocarditis, as I already told you, vegetations which may dislodge during the perioperative period, clots and volume and pressure overload. So as an anesthesiologist, what are those signs or those findings that can give us a red signal about the patients? Those signs are depressed LV ejection fraction below 30%, grade 3 diastolic dysfunction, high gradient across the wall, aortic stenosis with depressed LV function. This is a very bad combination to have in a patient for non-cardiac surgery, or severe regurgitation with depressed ejection fraction. Again, this is a very bad combination to have for non-cardiac surgery. Severe pulmonary hypertension, presence of pericardial effusion, pulmonary embolism. So whenever these findings present in echo, you must explain the risk, you must shift the patient at tertiary care level, you must take adequate precautions about monitoring and work accordingly. That is the help of seeing the echo in details. So the take-home message is always see the report in detail. Echo report must be seen in the context of patient's clinical status, as I explained in number of examples. And if you feel after seeing echo report that there is a presence of diastolic dysfunction, you again reassess this patient for the presence of signs and symptoms of failure. This is very important. So these all are complementary to each other. Echo report is complementary to us to manage the patient in a better way, to make a good decisions about the patient, to improve his level of care not at from our level, but even a level of care at the setup, means at what setup you are working, at what setup you can shift this patient. You can explain the risk properly to the surgeon, to the relative, and seeing the echo report in details help us a lot during perioperative. Thank you very much for your patient listening.
Thank you, sir. You really had simplified the echo reports because it was a very knowledgeable lecture. We'll take the question after the Nilesh sir's lecture. Now I request Dr. Nilesh Juvekar sir for his lecture on what's new in the guidelines.
Share. Yeah.
Dr. Nilesh Manohar Juvekar sir is consultant cardiac anesthesiologist at Dinanath Mangeshkar Hospital, Pune. He is very well renowned cardiac anesthetist. He has 7 publications on his account. Welcome, sir. Now you please share your screen.
You'll have to stop sharing first.
I have stopped, sir.
No. Right? Okay. There it is.
Sir, your screen is visible.
Yeah. I'll get it done. Right. Please.
Yes, sir.
Is this correct now?
Yes. We can see the full screen now.
Yeah. So thank you very much for inviting me for this lecture. And good evening to you all. And my regards from Pune. So you must have seen my photograph. I have purposefully put that photograph because that is what I aim to become again. So similarly, I think that we should all aim at modifying our practices so that we practice evidence-based medicine. Okay, so let me go to the topic immediately. So the topic for today's discussion is cardiac patient for non-cardiac surgery. What's new in the guidelines? Now the latest guidelines for this particular topic are by the ESC, that is European Society of Cardiology, published in 2022. The ones before them were in 2014, both by ESC as well as by the AHA. Now, this being more than 100 pages document, I have tried to include whatever I thought would be sort of helpful for the non-cardiac anesthesiologists in order to modify their practice so that they will be considered as the ones practicing good evidence-based medicine. So, as it was already mentioned that the volume of non-cardiac surgery all over the world has increased tremendously. Nearly 300 million, that is 5% of the world's population, undergo non-cardiac surgery every year. And of that, around 85% of the major operations are non-cardiac surgical procedures. So, in a data which was published by the US registry, nearly half of the adults undergoing major non-cardiac surgery presented with at least 2 cardiovascular risk factors. 18% had diagnosed coronary artery disease, 4.4% had history of stroke, and so 7.7% has the RCRI, that is revised cardiac risk index score of greater than or equal to 3, which means that the mortality is more than 11%. So the overall population or the risk profile of the patients coming for non-cardiac surgery has increased significantly. So that is why we need to know how to manage these patients. Again, in a large registry, amongst the patients who were cardiac patients who had history of PCI, around 11% had their operation in the first year and 24% by the 3 years after the PCI. Similarly, there was one more study done in Switzerland, and based on that study, they have extrapolated that what would be the major cardiac or cerebrovascular complications occurring in all the EU countries together. And they found a staggering number of 660,000, that is 660,000. So you can imagine that if that is the case in well-developed countries with good medical care, what will be the magnitude in a country like India? I think it can just wreak havoc. So the sort of recommendations of the 2022 ESC guidelines is basically to prevent perioperative cardiovascular morbidity and mortality, like perioperative MI, perioperative or stent thrombosis, acute heart failure, hemodynamically relevant arrhythmia, pulmonary embolism, ischemic stroke, bleeding complications associated with antithrombotic treatment, and even death. So surgeries are basically classified into 2 types. One is depending upon their the sort of risk involved, and second is depending upon when that surgery is done. So the timing of the surgery. So depending upon the risk involved, they are so classified as low risk surgery, where the risk is less than 1%. Then these are intermediate risk surgery, where it is around 1 to 5%, and these are high risk surgical cases where it is more than 5%. So we have to grade our surgery into one of these 3. So whether it is low risk, intermediate risk, or high risk. And secondly, depending on the timing of surgery, they are further classified as emergency, where it should be performed without any delay to save life or organ function. It can be sort of urgent, where it should be performed without unnecessary delay. Then time sensitive, where it should be performed as soon as possible after optimizing the patient, like the cancer surgeries and carotid endarterectomies or carotid stenting, where in order to prevent stroke. And sort of the elective, where it can be done at our own sweet time. So the cardiovascular morbidity and mortality are determined mainly by the 3 factors, that is the patient-related risk, the type of surgery, and the urgency, whether it is elective or whether it is emergency. And the risk may be reduced by adequate preoperative evaluation and proper selection of type and timing of the surgical procedure. So now the patients, all the patients should be stratified into one of the 3 categories. That is, people who are less than 65 years of age with no cardiovascular risk factors. Second is who are more than or equal to 65 years of age or with cardiovascular risk factors. And thirdly, when the age is not known, with established risk factors. So now let us see one by one. So if the patient is less than 65 years with no cardiovascular risk factor and is undergoing low to intermediate risk surgery, then no cardiac testing is needed. Okay, so you had already seen the list of the intermediate risk surgeries. So many of the surgeries that we think are high risk are actually intermediate risks. And so in those patients, we do not need any cardiac testing, especially echocardiography, which is the hot favorite of all the anesthesiologists and even most of these sort of physicians. Then these sort of high-risk surgeries, here the ECG and biomarkers should be done. Whenever it is a class 2A indication, I will be saying should. Whenever it is a class 1 indication, I will be saying must. Okay, so they should be done. So the ECG and biomarkers should be done in these patients if the age is more than or equal to sort of 45 years of age, that is class 2A. And ECG and transthoracic echo are recommended in these cases only if they have got family history of genetic cardiomyopathy. Okay, now coming to the second group, that is patients who have cardiovascular risk factors or who are more than or equal to 65 years of age. So if they are undergoing low-risk surgery, then no cardiac testing is required. You see, these are the patients who have got cardiovascular risk factors, but still, if they are undergoing intermediate and high-risk surgery, then ECG and biomarkers, they are class 1 indications. So what has changed from the last guidelines is that in the last guidelines, it was only patients with cardiovascular risk factors should undergo ECG. That was a class 1, but now they have included age of the patient, which should be more than or equal to 65 years. And assessment of, and even these are biomarkers. Okay, so we'll be talking a little bit more about biomarkers in the next 1 or 2 slides. But biomarkers which were class 2B indication in the 2014 guidelines have now been made class 1. And these are functional capacity assessment by various scores like the sort of MET scale or the Darcy score. They carry a class 2A indication. So these type of patients, they are only in those patients who carry intermediate and intermediate and high risk surgery. Now coming to those with established risk factors. So whatever we have discussed till now, they all hold true in cases of low and intermediate risk. But in high risk surgery, in addition to all this, cardiology consultation and a multidisciplinary discussion is a must. So these are the cases, because in our hospital, our cardiologists are really fed up. They say that in their OPD of whatever 40, 50 that they see in their 3.5 hours, around 10 patients are the things that they should not be seen. That is because unnecessary patients are being referred for cardiology consultation. So if we know that which type of patients should be referred to a cardiologist, then it would be very good. So that is the main purpose of these guidelines. Okay, now coming to this algorithm. Okay, so whatever we have discussed till now about intermediate, low risk and high risk surgeries and the investigation, what we should not be forgetting is the one over here, which is in green. That is class 1 indication. What is that? Accurate history and clinical examination, including the standard lab test and basic the sort of preparation of patients, like cessation of smoking for 4 weeks, or the guideline recommended medical therapy. These should never be forgotten when we are dealing with all these type of patients. Now, as I said about biomarkers, if the patient is more than 65 years of age, or if the patient is having a known cardiovascular disease, then and who is undergoing intermediate or high risk non-surgical surgery, in them TROP-T or TROP-I should be done before as well as 24 to 48 hours after the surgery. It is a class 1 indication, while pro-BNP or BNP, they carry a class 2A indication. Initially, in the previous guidelines, these biomarkers, as I said, carried class 2B recommendation. However, routine biomarker measurement is not recommended in low-risk patient undergoing low or intermediate risk surgery. So it is only for the high-risk surgery patients. Now coming to the hot favorite of all, that is the transthoracic echo. So let us start from down, that the routine preoperative evaluation of LV function is not recommended. Okay. However, then when should transthoracic echo be ordered? Okay. So if the patient is basically posted for sort of elective or an urgent surgery, whatever type, and is having a poor functional capacity, or is having a high biomarkers, or if patient has murmurs which are detected before high risk non-cardiac surgery, only then we should be ordering a transthoracic echo, we must be ordering. That is a class 1 indication. But if we find that the patient, if by our examination and history, if we suspect that the patient may have a new cardiovascular disease or has unexplained signs or symptoms before high-risk non-cardiac surgery. Okay, so if it is before high-risk non-cardiac surgery, it is a class 2A indication. But if the same patient is for an intermediate risk surgery, then it becomes a class 2B sort of recommendation. So we can see how the echo ordering and echo we should be decreasing in our day-to-day practice when we are practicing non-cardiac surgeries. And one more thing, that in all the workshops nowadays, there is a FATE workshop or a focus workshop. And if you have a person who is trained in a focus examination, then it has been said that it may be done as an alternative to a proper transthoracic echo by a cardiologist in order to triage these patients, means in order to segregate those patients who have got a significant cardiac abnormality. Now, sort of stress imaging. So where should that be done? So again, routine stress imaging is not to be done before non-cardiac surgery. Only those patients who are posted for elective high-risk non-cardiac surgery and have poor functional capacity with a high likelihood for coronary artery disease, then it is class 1. But if the same type of patient is posted, is already has undergone a PCI or CABG, then a stress imaging in them should be done, but it carries a 2A type of recommendation. Okay. Now coming to coronary angiography. Now, this again depends on whether the patient has got a chronic coronary syndrome or a acute coronary syndrome. So in patients with chronic coronary or what we call as chronic stable angina, routine preoperative angiography is not recommended before low or intermediate risk non-cardiac surgery. However, if they are undergoing surgical carotid endarterectomy, then it may be done. Why is that? Maybe because during carotid endarterectomy, there are a lot of sort of pressure sort of fluctuations which occur, and as a result of which patient might land up into myocardial ischemia or even infarction. So if you have a patient in whom you are suspecting a coronary artery disease, but the patient is unable or is unsuitable for non-invasive functional testing, and he is undergoing non-urgent, intermediate or high-risk non-cardiac surgery, then we can try and rule out his coronary artery disease by a CT coronary angio. And a class 1 indication for coronary angio is it has all the same indications what you would do for a patient in the non-surgical setting. Now, this is one thing which has been gaining importance in the preoperative evaluation of the patient, and that is the frailty index. There are sort of various scores which tell you about the frailty of the patient, and they should especially be applied to the patients who are more than 70 years. Why is that so? Because that gives you a more sort of correct type of sort of estimate of how this patient would do in the postoperative period. Okay, so there might be a lot of patients whom we feel that this patient might not do well, and you feel that why is the score showing such a low type of morbidity or mortality? That is because we have not added the frailty index. There is no score yet which adds this frailty index. So we should be adding it in our day-to-day practice. It carries a 2A indication, and also I am sure everybody asks how many flight of stairs can you climb, and we say that if a patient can climb 2 flights of stairs, then it is a fairly good effort tolerance. Obviously, it is more than 4 minutes, and then we can go ahead with the surgery. Now, the general risk reduction strategy, as I said, like cessation of smoking or control of the cardiovascular risk factors, including blood pressure, dyslipidemia, diabetes, they all have to be done. It is must, class 1B indication. Now coming to the pharmacological management. There are patients on lot of drugs. There is a lot of questions on which drugs can be initiated, which drugs must be continued, and which drugs must be stopped. So if your patient is preoperatively on beta blockers or is on preoperative or statins, then they must be continued. If the patient is not on statins but has an indication for statin, then it sort of should be started in the preoperative period. However, if the patient is having either risk factors for myocardial ischemia or for the cardiovascular disease, or is having a known coronary artery disease, then in these cases we may initiate beta blocker in the preoperative period. However, routine initiation of beta blocker is not recommended. Now, as we all know that many patients nowadays are on these RAS inhibitors. So if the RAS inhibitors have been started for heart failure, then in these patients it is always better that you may continue these in the perioperative period. However, if they are started for the indication of hypertension and not for heart failure, then it is better that you avoid the morning dose in order to prevent hypotension. Also, patients on diuretics which have been started for hypertension, always better to discontinue them on the day of surgery. Nowadays, a lot of patients are on SGLT2 inhibitors, that is the dapagliflozin, Daplo. So they have been started because nowadays they have got anti-diabetic effect, as well as they also improve the functional capacity of patients in heart failure. So if there are patients on these inhibitors, then you should be discontinuing them 3 days before intermediate and high risk non-cardiac surgery. Now, the most favorite drug of all the anesthesiologists is antiplatelets. So whether this patient will bleed or he will not bleed, when to stop, when to continue, this is all that we should be looking into. And so in order to simplify matters, surgeries are classified as surgeries with minor bleeding risk, surgeries with low bleeding risk where the chance of bleeding is infrequent, or they have a very low clinical impact, that bleeding has a very low clinical impact, and surgeries with high bleeding risk where they have got frequent episodes of bleeding or with significant clinical impact. Right. So this is an algorithm which will tell you that if the patient is on dual antiplatelet agent and he needs to undergo surgery, then first is we should ask the question, is there a high bleeding risk? If the answer is no, then we can continue the DAPT. But if the answer is yes, then we have to look into the patient's thrombotic risk. That is, if he has undergone PCI less than 1 month, he has ACS, that is acute coronary syndrome, less than 3 months, okay, or high risk of stent thrombosis. If the answer is no, then we should continue the aspirin. Nowadays, it is a class 1 indication. In the previous guidelines, it was said that you may continue aspirin as per the sort of physician's expertise, and it carried a class 2B indication. So it has been drastically, the sort of indication has been jumped from 2B to class 1 indication. However, the P2Y12 inhibitors should be stopped, like ticagrelor 3 to 5 days, clopidogrel 5 days, and prasugrel 7 days. The most deadliest of all is this prasugrel. Okay, because whatever you do, it is very difficult to control the bleeding, even if you give this patient platelets. Now, if the answer to high thrombotic risk is yes, then we should know whether it is a time-sensitive surgery. If it is not a time-sensitive surgery, you can easily defer it. Then it is best to defer the non-cardiac surgery class 1. But if it is a time-sensitive surgery and you cannot defer it for the recommended period, then you have to bridge it either with a GP2B3 inhibitor or with cangrelor, which is an IV P2Y12 inhibitor. We will be seeing how to this is sort of bridge it in the further slides. Now, this is a very nice slide. So what it shows is that if your patient is on P2Y12 inhibitors after a coronary angioplasty, then when can we safely undergo surgery and when we should not be interrupting it? So these two are most important. So that depends on whether the PCI was done for chronic coronary syndrome or it was done for acute coronary syndrome. So if it was done for a chronic coronary syndrome, we can safely stop them after 6 months. So the elective surgeries in these type of patients should be done after 6 months, while if the same angioplasty has been done for acute coronary syndrome, the same surgery should be done after 12 months. Okay, so it is you can safely stop them after 6 months and 12 months respectively. If it was done for chronic coronary syndrome, you should not be interpreting it. You must not at any cost be stopping it less than 1 month for chronic coronary syndrome and less than 3 months for acute coronary syndrome. So if you have to perform the surgeries in this period, then comes the problem of bridging. So now what is bridging? So as we have mentioned that low dose aspirin should be continued throughout. In the top one is given with GP2B3 inhibitors, that is IV tirofiban or eptifibatide, and the lower one is with infusion of cangrelor, which is a injectable P2Y12, like what we have like sort of Brilinta or Axer. The same way the ticagrelor, this is cangrelor. Okay, so if we have to bridge, then this prasugrel has to be stopped 7 days before. Clopidogrel or ticagrelor has to be stopped 5 days. Even clopidogrel you can stop 3 days before. And at 3 days before surgery, we start an infusion of tirofiban in the ACS dose. And that is continued up to 4 to 6 hours before surgery, where it is omitted to perform the surgery. And after 4 to 6 hours of surgery, depending upon what is the bleeding risk, and after a interdisciplinary type of discussion, we can either restart the GP2B3 inhibitors or directly load the patient again with clopidogrel 300 milligrams and followed by 75 milligram only. Similarly goes with cangrelor. The only difference here is that cangrelor has got a very short half-life, and so it can be safely discontinued 1 hour before surgery and restarted around 4 to 6 hours post-surgery. Okay, so apart from whatever we have discussed, what is different in these guidelines is this class 1C indication is for patients undergoing high bleeding risk surgery, example intracranial, spinal neurosurgery or vitreoretinal surgery. It is recommended to interrupt aspirin, which we saw that we should be continuing it for at least 7 days pre-operatively. And if the antiplatelet has been interrupted before the surgical procedure, then it should be started as early as possible, but at least within the first 48 hours after the surgery. Now, as we saw about antiplatelets, now comes anticoagulants. So anticoagulants, as we all know, are of two types. One is the VK, like your warfarin or aciclovir, or the NOACs. People still call it newer oral anticoagulant. They are no longer new. So some people call it DOACs, that is directly acting oral anticoagulants. So if there is a if the chance of high bleeding risk is not there, then we can safely interrupt them for a small period of time and no bridging is required. But if the bleeding risk is high, then if the answer is yes, then we have to look into the thrombotic risk again. So the main thrombotic what we come across is the mechanical heart valve, which are on VK. The NOACs are not licensed for use in patients with mechanical heart valves. So these patients will only be on VK, so they have to be bridged. They are bridged usually with unfractionated heparin, or now with the latest guideline, class 1 indication is we can even bridge them with low molecular weight this heparin. And if it is possible to defer the surgery, we have to defer. But if not, then we have to bridge the VK as well as NOAC for other type of thrombotic tendencies. Okay, now amongst NOACs, what we have to know is what is the molecule which the patient is on, what is the type of bleeding risk in the surgery, and thirdly, what is the patient's creatinine clearance. So dabigatran, as we all know, is a direct thrombin inhibitor, while the other three, that is apixaban, rivaroxaban, and endoxaban, they are factor 10A inhibitors. So dabigatran is not licensed for use in patients whose creatinine clearance is less than 30. So if your patient is on 10A inhibitors and if they have high bleeding risk of surgery, then they have to be stopped for 48 hours before surgery, irrespective of the creatinine clearance. However, if it is for low bleeding risk, then we can stop it 24 to 36 hours prior. However, for dabigatran, the thing is different. It is 96 hours for high bleeding risk surgery with a low creatinine clearance. We have to stop it for 96 hours after surgery. So these values are what we should always know when we are dealing with these type of drugs. Now, apart from what the guidelines for oral anticoagulants, so whenever a patient is on dabigatran and is to undergo an urgent surgery or an emergency surgery, and if its antidote, that is idarucizumab, if that is available, then that should be used. It's a class 2A indication. For our spinal or epidural anesthesia, very important. It carries a very high bleeding risk. So interruption of NOACs should be done for up to 5.5 half-lives. And the reinitiation should be done after 24 hours of our spinal anesthesia. And whenever a specific reversal agent, like the apixaban has a specific reversal agent in the form of adnexanet. So if these specific either idarucizumab or adnexanet they are not available, then activated prothrombin complex concentrate should be used in order to reverse the effect of NOAC if a urgent or an emergency surgery is needed. And most important, use of reduced dose NOAC to attenuate the risk of postoperative bleeding is not recommended. It is a class 3 indication, harmful to the patient. Now coming to coronary artery disease. Okay, so routine myocardial revascularization before low and intermediate risk non-coronary surgery, non-cardiac surgery in patients with chronic coronary syndrome is not recommended. Okay, again, this recommendation will differ based on what is the type of the coronary artery disease, whether chronic or whether acute coronary syndrome. Now, when is the sort of myocardial revascularization recommended? So you will see that for chronic coronary syndrome, the best possible recommendation is 2B, means it may be done. It is not like should be done or must be done. And that too in which patients? Patients who are undergoing high risk elective non-cardiac surgery, and they are done depending on three things. One is the amount of ischemic myocardium, more than 20% they are recommended. Patients who has got refractory symptom despite optimal medical therapy, or patient on coronary angio has got a tight left main disease. So even with this type of there is no recommendation which says that doing it for sure will alter the post-operative outcome. However, if the patient is having acute coronary syndrome and it is possible to sort of postpone the surgery for a minimum of 3 months, then that should be done. And the patient should undergo diagnostic and therapeutic intervention, either PCI or bypass surgery as per the sort of patient's need. And in the unlikely combination, this is very rare, like patient has got a life-threatening non-cardiac surgery also needed, as well as the acute coronary syndrome which needs revascularization. So if such a situation arises, then you should have a type of heart team approach and a type of multidisciplinary discussion as to what should precede what, whether revascularization should precede the non-cardiac surgery or vice versa. And many a times in these, so specialists will come to a conclusion that possibly bypass will be better because interruption of the antiplatelets is much easier in case of bypass than in case of angioplasty. Now, as far as the chronic heart failure does, only two basic thing is that they should be well investigated before surgery by echocardiography as well as the biomarkers, and whatever medications they are on should be optimized before non-cardiac surgery, class 1 indication. Now, valvular heart disease. This is a knowledge about this is essential because the anesthesiologist should know which cases he can do in a patient of non-corrected valvular heart disease. So if a patient has got aortic stenosis, basically the stenotic lesions are more dangerous than the sort of regurgitated lesions. In that aortic stenosis, again, they depend on whether it is symptomatic or asymptomatic. So if you have got a symptomatic aortic stenosis and he is scheduled for sort of elective, intermediate or high risk non-cardiac surgery, then either a surgical AVR or a transcatheter AVR can be must be done in these patients. However, if these same patients are asymptomatic, okay, then the heart team approach should be taken as to whether the aortic valve this sort of replacement needs to be done. And if for some reason aortic valve replacement is not possible, then a balloon aortic valvotomy may be considered as a bridge to a definitive aortic valve repair. Now coming to aortic regurgitation. So in that again the same, patient should either be symptomatic severe AR, or if he is asymptomatic, then his LV should be dilated. He should have LV dysfunction. Now you will see here that the LVEF of less than or equal to 50% is categorized as LV dysfunction in case of AR, and in case of MR, LVEF less than 60% is so even a slight decrease in LV function in case of MR is considered to be a indication for surgery. So in these cases, you must do a AVR before elective, intermediate, or high risk non-cardiac surgery. If the patient has got mitral valve stenosis, then two things. One is either a symptomatic moderate to severe rheumatic MS, or patient has got no symptoms but his pulmonary artery pressure, systolic pulmonary artery pressure is more than 50 millimeters of mercury. In these, the valve intervention, either a balloon mitral valvotomy or a surgery proper is recommended before elective, again, intermediate or high risk non-cardiac surgery. In case of mitral valve regurgitation, all these are class 1 indications, but for mitral valve regurgitation, it is a class 2A indication. Now coming to arrhythmias, we are nearing the end of our topic now, that arrhythmias, if they are supraventricular in nature and they are well controlled with antiarrhythmic drugs, then they must be continued, class 1 indication. However, if the patient is symptomatic despite optimal medication or is having recurrent or persistent supraventricular tachycardia, then ablation should be considered if he is undergoing high risk, non-urgent. So this is only for high risk, not for intermediate risk. However, if the patient is having ventricular arrhythmias, then in this case, it is a must for them to undergo VT or VF ablation, VT ablation before non-cardiac surgery, any form of elective non-cardiac surgery. However, if the patient has got asymptomatic VPCs prior to non-cardiac surgeries, it does not need any sort of treatment. As per this tachyarrhythmia, let us come to if there is a bradyarrhythmia. If there is any indication of pacing and it is an elective non-cardiac surgery, that should be deferred, and the pacing or a CRT, that is cardiac resynchronization therapy, should be done before the non-cardiac surgery. And during non-cardiac, if a patient already has an implanted device, be it a AICD or be it a pacemaker, and which has been deactivated, then the patient must be monitored. The ECG must be monitored in the perioperative period, and by whom? By a skilled personnel who are skilled, who are experts in detection and treatment of arrhythmia. However, if the patient is pacemaker dependent or has an AICD in place which is deactivated, or if their torso is not accessible to placement of pads, then in these patients, disposable transcutaneous pads should be applied before non-cardiac surgery. Okay, so this is about the arrhythmias. Now, pulmonary hypertension, which is again one of the deadliest problems which the anesthesiologist faced and very difficult to manage. So, if this patient is on chronic therapy, then all those drugs must be continued in the perioperative period, and these patients must be monitored for at least 24 hours in the post-operative period. And secondly, if they develop symptoms of heart failure in the perioperative period, then we should optimize or increase their diuretics or start other drugs. Now coming to arterial hypertension. Okay, so in the previous 2014 guidelines, it was said that patients with stage 1 or 2 arterial hypertension may be postponed if they are undergoing elective non-cardiac surgery. But now, so maybe means 2B. But now it has been said that you should not be deferring non-cardiac surgery in patient with stage 1 or 2 hypertension. But there it was mentioned in 2014 that you should, a 2A indication, that you should be preventing arterial hypotension in this patient. And how was that hypotension defined? It was defined as a decrease in mean arterial pressure less than 60 millimeters of mercury for more than 30 minutes, cumulative. But now it has been said that now it has been upgraded to a class 1A indication. And how is this hypotension defined? It is defined as a pressure, mean arterial pressure less than 20% from baseline or less than 60 millimeters of mercury for more than 10 minutes. So much is the sort of threshold for arterial hypertension. The values has come down. Why is it important? That is especially in cases of surgeries where we need induced hypotension. in these, how much BP we can safely get down and for what time, that the anesthesiologist has to know. I'll just skip this slide. Now, another most common problem in India is diabetes mellitus. It was first said that you should be doing HbA1c in patients undergoing elective non-cardiac surgery, but now it is said that you must be doing. So class 1 indication, and if it is an elective surgery and if the HbA1c is more than 8.5, then you must be postponing these type of surgeries. Okay. Now, as far as the patient blood management goes, so it is the RBC containing blood products which increase the perioperative morbidity and mortality. So treatment of anemia in the preoperative period must be done. And if the blood loss estimated is more than 500 ml, then use of a cell saver is a must. And also you must be using point of care testing in order to guide the blood component therapy like the ACT or the TEG. And in patients undergoing non-cardiac who experience major bleeding, you should be administering tranexamic acid immediately. Only two are remaining, which have been added newly in these 22 guidelines. One is cancer, because there is increased prevalence of comorbidities related to cancer and cancer-related treatment. And in these patients, there is more of a thrombotic risk. So there is increased thrombosis is due to malignancy per se, or the cardiotoxic neoadjuvant chemotherapy and chest radiation. And because of all these three things, it imposes an increased cardiovascular risk. And what we all suffered in the last 2-3 years was COVID-19. So they found that there was increased morbidity and mortality if the non-cardiac surgery takes place less than 7 weeks from the time of COVID-19 diagnosis. However, the problem was that the data was collected from unvaccinated patients, and the outcomes among the vaccinated patients was currently uncertain. So how much to believe in this particular recommendation, we don't know. But they found that if the patient had persistent symptoms of dyspnea, chest pain, or fatigue, then these factors increase the risk of perioperative mortality, regardless of the timing or relationship to the COVID-19 infection. So the take-home message is that the risk of cardiovascular complications in non-cardiac surgery is determined by patient-related factors, type of surgery, and the urgency of the surgery. Specific patient-related risk factors can be reduced by adequate preoperative risk assessment and initiation of effective risk reduction strategies. Quantification of the surgical risk as low, intermediate, or high helps in identification of patients who would benefit from evaluation and intervention. And proper selection of type and timing of surgery may reduce the risk of complications. The sort of frailty screening should be incorporated in assessment to get a realistic assessment of the outcomes. A multidisciplinary approach is better to evaluate whether treatment of concomitant cardiac conditions must precede the non-cardiac surgery. And lastly, efficient management of antithrombotics in the perioperative period helps prevent thrombotic events without increasing the bleeding risk. I hope everyone is not like this. I would be happy to answer questions. Thank you.
Sir, for updating us about what's new in the guidelines. There are a few questions for Balaji sir. Balaji sir, should we start Q&A session?
Yes, madam.
First question is, which grade of diastolic dysfunction is alarming for us?
Grade 3 diastolic dysfunction and grade 2 diastolic dysfunction with symptomatic patients are alarming for us.
Okay, sir. Thank you. The next question is from Parna madam. It's written that LVD is 60 millimeter. What does it suggest?
LV, it's nothing but the internal diameter of the LV. Normally, it's up to 60. And if it is increased, it is an indirect indication of improper LV function. Secondly, increased LV dilatation is an independent factor for cardiac morbidity in perioperative period. Thirdly, whenever there is a LV dilated, chamber dilatation, global chamber dilatation occurs, usually there is a associated regurgitant lesion occurs, like mitral regurgitation. Okay. On that aspect, we have to evaluate the patient. Suppose there is a dilatation of LV.
Thank you. The question is from Umesh Ramtani, sir. He is asking that what's the medical status of a cardiologist opinion pre-operatively, whether it is must or not, especially in medical teaching institutes.
No, as I already said, that only for the high risk for the patients who are more who have got high risk, who have got cardiovascular risk factors and going for high risk surgery, only though they need the cardiology opinion.
Okay, sir. Thank you. One more question is from Vinay Kulkarni, sir, to Balaji, sir. Dr. Balaji, sir, your comment on learning echo in anesthesia training. Are we there now?
Yes, madam. Ideally, it should be there as we are learning ultrasonography guided block. At least for focus type of courses, and at least you should have assessment, basic assessment of heart. You should be proficient at assessing the heart in perioperative period. Not only preoperatively, even intraoperatively, whenever patient goes in shock, there is a confusion, there is a hypotension. If you just keep the probe, and if you can gather a lot of information which can help you in making important decisions regarding patient management.
Yes, sir.
And if I may add, there was a study which was conducted on patients who underwent not for patients, sorry, on trainees who conducted or who attended the FATE course. So they found that if they have undergone 20 hours of training, then they could easily interpret more than 90% of the abnormalities, more than 90% of the times. So every anesthetist should undergo training in the FATE or the POCUS examination.
Yes, sir. Thank you, sir. These were the questions. If more questions come for the discussion, then we'll discuss in panel discussion. Nilesh, sir, please stop sharing your screen, sir.
Oh, yeah.
I request all the participants to put their video on so that we can take a photograph. कैसा आएगा पीछे? Now let's move to our next session, that is panel discussion. For panel discussion today, we have a expert Murlidhar Kanchi for his expert comments. Dr. Murlidhar Kanchi is professor and senior consultant of anesthesia and critical care at Narayan Hrudayalaya Institute of Allied Health Sciences of Bangalore. His area of expertise are cardiac anesthesia teaching and research and transesophageal echocardiography. He has publications national and international about 120. He has also received a Rukmini Padmini Award for the best research paper at ISA 1990. Now I hand over the session to Dr. Vinay Kulkarni, sir.
At the outset, am I audible?
Yes, sir.
Yes, sir.
Okay. So good evening, everyone. And at the outset, I thank the organizers, ICA NCB team, and SAMS for giving me this opportunity to be a part of this important topic. And I also take this opportunity to welcome all our faculty panel. In the meanwhile, I'll just start. Can I start sharing my screen?
Yes, sir. You can share your screen.
Okay, just a sec.
Till that, we have one more question from Gauri Madam. ISA guidelines does not give any recommendation of echo. What is your take on this for Juvekar, sir?
Which sort of guidelines?
ISA guidelines does not give any recommendation of echo now. So what is
possibly
your...
possibly I feel that everybody feels that we should have an echo. But
we have to take
but Balaji, but Dr. Asegaonkar has already told us what are the sort of shortcomings of an echo. Patient with 99% left main, as he showed, can have a normal echo.
Sir, thank you. I hope Gauri Madam is clear now. So, Vinay sir, are you
Yeah.
able to share your screen?
Yes.
Madam, and another thing is that all these guidelines about echo are from the Western countries where they don't have people to perform echo. Okay, here we perform 100, 200 echoes in a day, and there if you want an echo, you get an appointment after 2 months. So
Yes.
maybe that is the reason why they are going down on the need of echo in the perioperative period.
Absolutely true. You are correct. All the guidelines are also guided by the local conditions.
So,
is it your
yeah.
slide? Okay.
Yeah.
Thank you, sir.
So, welcome everyone for this interesting panel discussion on various level of cases which we practice in our day-to-day anesthesia practice. I thank ISA-NCB team and SAM's team for giving me this opportunity. I also thank our key faculty, Dr. Sri Krishna Deshpande sir, Dr. Nilesh Zuvekar, Dr. Sandeep Diwan. I'm sure let us see if he can join us. Dr. Rahul Pingle, Dr. Srikant Bobde, and Dr. Kanchi Murlidhar sir. We all have experts on our panel today, and we'll go through the cases one by one. So, what the protocol for this discussion, what we have designed is we have 6 or 7 cases which we want to go through, and each one of the panelists will be assigned one case, and at the end of that case, uh, we can have a quick recap on what should be done. And Dr. Murlidhar sir, we will request him to give his expert comments on that. So this is just introduction for Dr. S.K. Deshpande sir. He's a well-known faculty, well-known face in cardiac anesthesia all over the country and in Nagpur. He's established so many centers in Nagpur, and now he's the organizing chairman of Actocon 2024, and myself being the secretary. We have already welcomed Dr. Murlidhar sir. He actually needs no introduction. And Nilesh Javekar sir, we've already seen his talk, excellent coverage of the topics. But Sandeep Diwan, to my understanding, is one of the best exponents of regional anesthesia. I wish we could get him here. Srikant Bubde, we work together. He's a consultant cardiac anesthesiologist and intensivist, founder of WACA, our group. Rahul Pingle is my good friend. He's practicing as an anesthesiologist in Akola. He's director of the Ozone Super Specialty Hospital, and he's a familiar face at Akola. So the first case right now, we start with the first case. Dr. S.K. Deshpande, sir, we have this case for you. This is an 80-year-old patient with severe aortic stenosis posted for bipolar hemiarthroplasty. The background of the patient, what we know about is he's able to do basic activities independently at home without assistance. This is before he had a fall in the bathroom. He doesn't have any angina or dyspnea on routine activities. This again before the fall. On examination, his heart rate was 74. His blood pressure is 100 by 70. He doesn't look to be in any kind of obvious heart failure. On his evaluation of his X-ray, he's got a mildly enlarged heart size, but lung fields are fairly clear. There is obviously no sign of pulmonary edema or congestion. His ECG shows left ventricular hypertrophy with a strain pattern, and his echo now shows up as a severely stenotic aortic valve with a gradient, the peak gradient of 74 millimeters of mercury, which is significantly high. Concentric LVH, but fairly preserved left ventricular function with diastolic dysfunction. So these are the parameters which we have. Is not on any antiplatelets, and the surgical plan is bipolar hip arthroplasty. So, so now with this kind of data, uh, uh, is there anything that you would want to help you decide this plan for anesthesia?
Thank you, Vinay, and thank the organizer for giving me and Vinay the opportunity to be a part of this wonderful program. And as Dr. Juvekar has said, that focus should be learned by all the anesthetists, and in the Actocon 2024, we have got one workshop dedicated for focus. So I appeal all of you to attend and register yourself for the focus workshop as well as the CT workshop. Now let us come to the case. We know that this patient has got a severe aortic stenosis, and the gradient is gradient is 74. So naturally, this patient has got a low fixed cardiac output with a concentric LVH and LVDD as to grade 2. So naturally, these patients are with BP of 100/70, means LV pressures are about 170 or 180. So he is already compromised because he has got age-related issues also. Because of the aging, the muscles they become more fibrous and this is a chronic lesion. So he will not tolerate any hemodynamic imbalances. The best thing for me, if I would be giving anesthesia to this patient, I would just go ahead with I don't require any more information, and only thing is I will assess his airway because I would like to give general anesthesia to him. I will ask any allergy to the local anesthetic agent he has got earlier in earlier surgery he has undergone, and whether he had sustained any stroke, because all the calcific aortic stenosis are known to have this kind of a problem, and this coronary angiography is not done. So usually these patients also have got associated coronary artery disease, or the calcification of the aortic valve extends to the ostia of left coronary ostium or right coronary ostium and may cause a coronary artery disease. So, so regional valve motion abnormality will be one guide, but otherwise, if possible, since it's a fracture patient, he can't be taken to the cath lab. So I think we will have to take him to the OT, and I would prefer to do a general anesthesia. Although the conditions are favorable for giving regional anesthesia, but considering his cardiac lesion, his age, I think the general anesthesia will be better. For the conduct of anesthesia, my intraoperative goals will be the pressure should not fall, because I consider that this patient is having an underlying coronary disease, because the LVDD 2 is, it means most of the time the LV is training to overcome the resistance offered by stenotic aortic valve. So there is a less time for diastolic relaxation and the coronary blood flow. So therefore, and plus, as you see in the LVH with trend pattern, it means already ischemic. So I must maintain the heart rate to the optimum levels, not too low, not too high. And my goals will be to maintain the heart rate within the my oxygen has to be good, because that is good for the heart. And of course, he should not have hypotension, because my coronary perfusion pressure will fall, and that will start a cascade, which is a negative cascading effect on the heart, and will have a hemodynamic crash during anesthesia. So this patient, I would like to do in a place where ICU management, ICU care is available, and I will inform the ICU staff and keep a ventilator standby in case the patient has got an intraoperative crash. It may not be required when we take precautions, but we should have a backup plan ready. So general anesthesia, having the ICU backup, and drugs should be loaded beforehand. So when I go to the OT, I will check the regular checkup, and if there is no airway risk, then routine anesthesia preparation. TTE will be handy. TTE may not be required, but TTE will be handy. But I would rather go for a invasive monitoring in this case. I will put after putting a peripheral line, put a arterial line under local anesthesia. So I will get a better monitoring of this patient. So invasive monitoring is a must. So those setup which have got this facility, and because this is a non-cardiac surgery, that's why I'm telling all these things. So, so arterial line will be a very good thing in this patient, and very essential probably. And if possible, as a precautionary measure, the central line also will be better. So all these things are to be put under local anesthesia, and the patient is then taken to the OT. I mean, in the OT we do all these things, and then go ahead with your general anesthesia. In general anesthesia, we have to choose those drugs which do not produce any hemodynamic issues. So what drugs are there? Regular, we have got a availability. Among the availability, the fentanyl is there, midazolam is there. Among the induction agents, we have etomidate, which is supposed to be causing less hemodynamic issues, and rocuronium or cisatracurium, whatever is your choice, on which you are used to. That can be the for intubation. Choline is best avoided because we want to maintain the NSR, and any arrhythmias to which these patients are used to, they are prone to. We should not induce any atrial fibrillation because the atrial kick is very, very important. So we have to maintain the rhythm properly. It is better to spray the cord beforehand or give a lignocaine nebulization so that the intubation related hemodynamic disturbance are avoided. And after intubation, the patients are maintained with standard maintenance of CO or ISO, whatever you have got, and arterial pressure monitoring there. Do not keep them too much dehydrated because in these cases we are really worried about too much of LVDD, and so sometimes we end up in leaving the patient too dehydrated, and that may be the cause of hypotension. So patient should be properly hydrated preoperatively during anesthesia, and the hydration will depend upon what kind of a blood rheology is telling you. If it is telling you that hemoglobin is low, then and if there is no much loss of blood, then you may not require any blood loss because there is no tourniquet over here because hemoarthropathy. So if there is a blood loss, then we have to arrange the blood. Otherwise, blood is mostly not required with the modern technique. However, one has to be ready with that, especially with the patient who is borderline, because these patients do not tolerate the hypotension due to any cause, maybe because of decrease in the pulmonary pressure, or decrease in the vasomotor tone, or whatever, or increase in the heart rate. We have to keep some vasopressor ready intraoperatively, and the most useful to which we are used to is the phenylephrine, which is kept in a diluted form. And on a backup, I would keep norepinephrine loaded onto the syringe pump. So my preparation will be that before I take the patient and induce. All the 5 leads are to be attached so that we can monitor the lateral wall ischemia changes, and then the patient is given position after intubation, and the surgery can go on. Or we have to also plan for the post-operative analgesia, and if possible, if we can get away with a reduced anesthetic requirement during anesthesia, which will have a sort of a less myocardial depression. So I think the best option will be to give some kind of a additional local anesthetic block. So fascia iliaca block is supposed to be a good in this case. So it is very safe. So fascia iliaca actually separate the femoral vessels from the underlying psoas major and muscles, and all the 4 nerves, which are sciatic nerve, femoral nerve, ocular nerve, and lateral femoral cutaneous nerve, are blocked, and that will take care of the analgesia. So ropivacaine, which is less cardiotoxic, is normally used 0.25 percent, about 15 ml. We use with 1% of lignocaine, and we have to use slightly more volume in that. And best thing to, although it's a blind technique, can be used, but best thing is to use a UAG guided fascia iliaca block. With this, we can, I think the patient should remain stable. We have to be very watchful about the arrhythmias, and any tachycardia has to be first analyzed why this tachycardia is happening. Are you giving less anesthesia? Is the patient dehydrated? Are my SpO2 and ATCO2 not right? Then we have to start the treatment. If the patient goes into fast atrial fibrillation, it could be just because of the lateral sense of anesthesia. So once you are happy about it, then go ahead with initially with a small dose of beta blocker, and otherwise we have to go for a amiodarone. Any hypotension has to be very quickly treated immediately. So that's why central line is very handy, because when you give the drug into the 3-way, it reaches the circulation very rapidly. And as we know, this is a patient with a low pitch cardiac output. Circulation time is longer, it is slower. So naturally, the drug is going to take some more time to act. So these things are needed. Once the patient surgery is done, then with this monitoring, of course, urine catheter is always there to check the urine output. The patient is to be shifted in the ICU. If you are happy about the recovery of the patient can be extubated on table. But if the patient, you feel that he's slightly not, or there are some events. So what will guide for ventilation is any untoward intraoperative event, excessive bleeding, prolonged surgical time, hypothermia, arrhythmias, multiple requirements of vasopressor intraoperatively. All these things will guide you that this patient is not stable and not fit for extubation. I think we should shift the patient to ICU and ventilate him for some time. If all these things do not happen, then the patient is okay. Then I think we should go ahead. ABGs are usually not required except for the monitoring of the potassium, because SpO2 and ATCO2 will give a good idea about your blood about the ventilatory and oxygenation management. But potassium and sugar are to be it's a good idea to have a potassium monitoring. If the potassium is on the lower side, then these patients the potassium is to be treated. These are and postoperatively the analgesia has to be, is the 80-year-old man, although the creatinine could be normal, but we always have to take into consideration that patient has a compromised renal condition. So we had to go for a multimodal analgesia. We already given a block. We can't repeat it in the postoperative period. So let us add paracetamol infusion 8 hourly, because this is the old man, so need not give 6 hourly, and small amount of fentanyl. These are the two things we can use as an analgesia to this patient. And this is going to be my broad plan of action.
Thank you, sir. That's a very perfect management strategy. I'm sure if there are students who are attending this, there could be nothing better than this in terms of how to manage a patient with aortic stenosis. This is all compiled right in front of you from so many books and with a lot of experience. I think we are all blessed to hear this from you. Thank you, sir. And in the meantime, I just had one question. Would you, like this being a risk factor for coronary artery disease also at this age, should we also look for troponins or some markers before the surgery? Because this was something just we just kind of got alluded to into Dr. Nilesh's talk. So should we be doing markers?
Since you in the history, it was told that the patient has been very stable and didn't have any crushing chest pain, or the fall. The cause appears to be a syncopal attack, which is classically associated with the aortic stenosis. Many aortic stenosis patients, they usually present with syncopal attacks. So I just thought that this could be a cause for the hip fracture. So I didn't think about that. But yes, biomarker, preoperative biomarkers will be handy. So otherwise, this patient from the history doesn't give me any suggestion that he has got a coronary event going on.
Yes, sir. Any
Can
comment?
I say something?
Yes, sir. Yes, sir.
That was a lovely presentation of the scheme of management of this patient who had severe aortic stenosis. The following points which have been highlighted is that avoid atrial fibrillation, have a ICU care team alerted and have a bed ready, include invasive monitoring, especially the arterial line, have a cardiac surgical backup, and then avoid dehydration, and have a scheme for the pain relief post-operatively. All these points are very, very important. And my take on this is that well, we have to know whether the patient is symptomatic or asymptomatic. If you think that the patient had a fall because of syncope, it becomes symptomatic.
Yes.
So once you have labeled him symptomatic, but if the surgery is emergent, surgery might have to be done irrespective of the fact that the patient has a cardiac condition which is serious enough to warrant that it should be looked at. That is one point. Second point I wanted to know is that the gradient was mentioned as 74. It was mentioned as peak, I guess. But we
Yes,
also
sir.
have to know what is the mean gradient. Suppose if there's a
Yeah.
element of aortic regurgitation with aortic stenosis, 74 peak gradient may not be that bad compared to a pure aortic stenosis. That is the second point I would like to make. Third point I would like to make is that ECG monitoring, as correctly pointed by SK, is absolutely mandatory. There's no doubt about it. But SK changes how much they will tell us about ischemia in the presence of LV strain pattern in these patients is difficult to judge. But if there is a dynamic change in the ST segment, that indicates to us that there is some element of ischemic pathology in this patient occurring at that point of time. The fourth point I would like to make is that when you talk about goals of management, heart rate has to be maintained, preload has to be maintained, afterload should be maintained or even increased, contractility should be maintained, and normal sinus rhythm is mandatory. The next point I would like to make is that Deshpande mentioned about avoiding myocardial. If you have facility to monitor this, you can actually titrate the anesthetic dose to the patient's response using the BIS as a guide to the titrating the dose of inhaled agents. These are some of my input into this. And also when you're putting the CVP line, you have to be careful that you do not irritate the atrium or the ventricle, which may lead to arrhythmias. It actually happened in one of the cases. So if it goes into VF, it's very difficult to bring them back. Cardiac massage will not work. And you have to give a DC shock immediately and then go on with that. These are some of my points. In addition to what SK said, SK was quite, he covered all the important aspects. Thank you so much.
Thank you,
Thank
sir.
you, Murli.
Thank you, sir.
It was a
Thank you,
nice
sir.
one. I just remembered the 1983 days.
Is it?
Okay, thank you, sir. Thank you, SK sir. Thank you, Murli sir, for this excellent comments for this. Can we go to the next?
The other thing is the aortic valve area was not mentioned.
Yeah.
Yes, sir. Yes, sir.
That's also a factor to be considered.
Yeah.
Thank you. Thank
Okay.
you.
Okay. Next case, Dr. Srikanth. We have a pediatric patient, a 3-year-old child with tetralogy fallow, uncorrected, posted for PSARP. The history goes that born with imperforate anus at birth and found to have cyanosis, then diagnosed as tetralogy fallow. He had undergone colostomy on the day too. Now 2.5 years they have been kind of going around here and there, not following the request for doing corrective surgery. Now they've come for they want to have the PSARP done to close the colostomy and get the thing functioning. So now the baby is come for surgery. Saturation is 78% on air. There is cyanosis. ECG shows typically right ventricular hypertrophy and right axis deviation. Typically, as we see in tetralogy of fallow patients, the lung fields are oligamic and the heart shape is boot shaped. So, so that is how it is. Echo shows VSD with right to left shunt, the aorta overriding or straddling the VSD, and infundibular pulmonary stenosis with a pressure gradient of about 40-45 millimeters of mercury. The hemoglobin for a tetralogy patient, this one is 12 gram%, slightly lower. The platelets are 1.8 lakhs, INR is 1.3, and the APTT is 40. So this patient is now come for PSARP, is uncorrected tetralogy. So, Dr. Srikanth, how would you kind of proceed with this case in your investigations, and what would be your goals in your during the case, and how would you plan the post-operative care?
Hello. Good evening, all. And thank you, Vinay sir. Actually, at the outset, I will discuss this case with my surgeon who is going to do a PSRP. So, whether he want to go ahead with the PSRP or he wants to increase the oxygen saturation of a patient after doing BT shunt or corrective surgery for tetralogy. That should be the first thing discussed with the surgeon because the wound healing is going to be an issue if the oxygen saturation is that low as around 78%. So that is the first thing we should discuss with the surgeon and the family. If even after interdisciplinary discussion, it is been decided that we have to go ahead with the PSRP because of social reasons and all, then my plan will be to discuss the risk with the family. Then I will keep the baby NBM for at least 4 hours before surgery. And during the NBM period, I will give the maintenance fluid to the baby. After that, and when the time of the surgery comes, I will pre-medicate the baby with the small dose of midazolam and some fentanyl. And after that, I induce the baby with ketamine. That is to maintain the systemic vascular resistance. After that, I will like to put invasive lines like arterial line for the baby because I wish to do ABGs intraoperatively, and I will also put CVP line on him because to give fluids and to give the vasopressor like noradrenaline and if required beta blockers and phenylephrine also. Once everything in its place, ECG, ETCO2, SpO2, invasive arterial line, CVP monitoring, then we can proceed with the surgery. During surgery, what my goals will be like, I will maintain the adequate fluid status. I will avoid hypovolemia. I will avoid the hypothermia. I will avoid the hypercarbia. I will check ABGs and avoid the metabolic acidosis in those patients because this is going to affect the pulmonary vascular resistance of this patient, and that will in turn affect the shunting, right to left shunting. So these are the things. These things are very important. If the patient develops some kind of hypotension, I will immediately correct with the fluid boluses and maintaining the SVR with the either with phenylephrine or noradrenaline. If at all patient goes into a spell, there is always a chance that your patient might go into spell because of the surgical stimulus induction and all. At that time, we have to treat the spell right away with the fluid boluses, correction, taking out the nociceptive stimuli, giving adequate sedation. If required, beta blockers like ismolol can also be given, and increasing SVR with the noradrenaline. After that, I will plan the analgesia for PSRP. I think in PSRP, the position will be prone. So we have so hello.
Hello. Yeah,
Am I
we can hear
audible?
you.
Yeah.
Yeah.
And the position is prone. There is a lot of dissection happens in PSRP. So you have to take care of all the pressure points and plan a proper analgesia. Like I will like to give the dexmedetomidine infusion like in a dose of 0.1 microgram per minute to this patient for some sedation and analgesia, and I'll also give the mol in a dose of 15 milligram per kg body weight 8 hourly to this patient. I will check ABG just after induction and before completion of a surgery in order to plan my extubation accordingly. If everything goes well, there is no untoward event and ABG is okay, ABG is good. There no acidosis. After correction of hypovolemia and adequate fluid stresses and adequately achieve maintaining the temperature of a baby, I will extubate the baby on table. If there is some problem issues inside during the surgery, I'll definitely try and ventilate the baby for some time, check ABGs, keep the baby warm, give adequate analgesia, and extubate the baby in ICU. So that is the kind of management I would like to have in this baby.
Would you give any blood products here?
Yeah, if it is required, definitely. If there is a significant blood loss, then I will do ABG, and if the hematocrit is there, as per the hematocrit, I will definitely give. But not blood products like FFP and platelets unless there is some bleeding, because the your coagulation parameters are very normal. You have given very normal coagulation parameters.
Yeah, his hemoglobin was 12 gram, which is low for a tetralogy. So maybe for that, what some blood would be okay, I thought. Okay.
Yeah, that is true. The hemoglobin of 12 grams is a bit worrisome because in a patient with tetralogy, you expect anything upwards of 16 grams per son. Being a cyanotic child, the most important concern here is that we should not precipitate tetralogy spell.
Yeah.
That is the only thing. And if it occurs, now we need to be very aggressive in management of the tetralogy spell. And if the spell is not reverting, you might have to consider emergency PT shunt, and hence the cardiac surgical backup should be available in such patients. And ketamine IV or IM you would like to give? That was not mentioned.
IV, sir. Yes, IV.
You would like to use IV.
Yes, sir.
How about the sevoflurane induction and putting IV line after the child is asleep?
Yeah, we can do that, but definitely there is some vasodilation occurs with the sevoflurane. So patient might again have a saturation might fall.
Sevoflurane, according to me, is quite safe. If you want to avoid crying and parent separation anxiety, you may actually take the parent inside the OT with the child and then make the parent sit on a chair or stool in the operating room close to the anesthesia machine, and the parent can administer sevoflurane, and in a minute's time child will be asleep, and then the parent can be accompanied outside by somebody else, and then you can continue the anesthetic. This is one option you have. And if you are using IV ketamine, if the patient is stable, about 1 to 1.5 hours prior, you can put Embla cream on the dorsum of the hands so that IV insertion will be relatively painless.
Yes, sir.
Yes, sir.
Thank you.
Recording in progress.
Thank you, sir.
Thank you, sir. That was excellent.
Excellent
Points covered.
Thank you.
Thank you.
So shall we go to the next topic? This is for Dr. Nilesh. We have got a 45-year-old male with a history of PTCA 3 months ago. Now he's come for a lab chole. The history being he had he's diabetic, basically diagnosed double vessel disease 3 months ago, and during his evaluation for an anti-wall myocardial infarction, and then post-infarction, he underwent an angiography, double vessel disease. He underwent PTCA to LAD and circumflex. He's on dual antiplatelets as per the clopidogrel. Now he's had repeated episodes of cholecystitis and he's been fairly stable from his cardiac point of view. He doesn't have any angina on exertion or dyspnea on exertion. He's able to climb almost 2 flights easily without any discomfort. Because of his repeated episodes of cholecystitis, every time he's been receiving antibiotics and supportive care. And now he has come for elective lab chole because that's what the surgical team has decided that he needs this one to get it done. Uh, these are these counts, bloods, total counts 12,000. His CRP is 46. His ECG, because of his old interval MI, QS in V1 to V3 and T inversion V4 to V6. A mild cardiomegaly on X-ray. Saturations are good on air. Chest X-ray is fine. It's okay. His echo shows mildly dilated LV and EF of 40%. Normal IVC size and mild MR. So this patient is now posted for an elective laparoscopic cholecystectomy. So your plan for this patient, Dr. Nilesh?
So number one is, if it is labeled as elective, then I will tell the surgeon to postpone it for another 9 months.
Okay.
So it cannot be an elective surgery which is posted 3 months after a angioplasty which has been done for an MI. As I told in the guidelines, for them, if it is elective, then 12 months you are not supposed to touch this patient. So let us assume that it is not elective. It is, despite antibiotics, we can say that the patient is not settling, and this patient is now, they are suspecting a gangrenous gallbladder or something, and that's why now this patient has landed with us for an urgent laparoscopic cholecystectomy. Does that sound good? Yeah. So if we have to anesthetize this patient now, the cardiac, as you said, is only 3 to 4 minutes, but still his ejection fraction is around 40. Okay, so number one is that it's a laparoscopic surgery where we are going to inflate the abdomen with carbon dioxide. If the surgeon, I will first ask the surgeon whether he is well versed with lapro lift. If we can use a lapro lift where we don't have to insufflate the abdomen with carbon dioxide, there these sort of hemodynamic fluctuations are less compared to if you have a patient of EF of around 40% and you inflate the abdomen with carbon dioxide. If at all he says, no, I don't have a lapro lift or I am not trained in a lapro lift, and he wants to inflate the abdomen with carbon dioxide, then that inflation of the abdomen has to be very slow. Otherwise, they normally just start the this, and if you have then you will see that the pressure falls. So pre-operatively, before we post this patient for the surgery, I will discuss with the surgeon that, okay, number one, you need to do this surgery. Only then I am going to touch him, because in the perioperative period, I have to stop his anti-platelet agents. Now, because he comes into a class 2A, okay, so first 3 months after acute coronary syndrome, it is class 3, means you are not supposed to. But now after 3 months, so it's been 3 months have gone, so now he comes into class 2A of so stopping the antiplatelet agents. And so in these patients, if we feel that he has already had some episode of angioplasty and then an episode of subacute thrombosis, so if he has got a higher thrombotic risk, then I would like to go for what I mentioned as a bridging therapy. And now with the newer available Cangrelor, it is much better or much superior, much easier to manage than the tirofiban that we used to use. Because in tirofiban, they have mentioned a very long, some people say 4 hours, some people say 8 hours. But in Cangrelor, it is 10 minutes to 1 hour. From 10 minutes to 1 hour, if you stop it before the surgery and reinitiate it immediately once your bleeding risk is less, which is much less in case of laparoscopic surgery, then I think we should be able to do it. So preoperatively, our antiplatelet management, and if as is having this and he is going in for a intermediate type of surgery, the class 2A recommendation becomes the biomarkers to know whether he is in failure or not. If his NT-proBNP is on the higher side, we would like to first optimize him with basically diuretics, and after optimal medical management, when the day of the surgery comes, that is the time when we post. So he normal nil by mouth guidelines. Now the newer guidelines say that you can give them sips of dextrose containing fluid, a carbohydrate containing fluid up to 2 hours prior to the surgery, clear liquids, and then once he is in the operation theater, standard monitoring followed by an arterial line at least. They usually will not need a central line, but an arterial line monitoring, because when they start insufflating the abdomen, the pressure goes down drastically. So we have to tell them based on our arterial pressure, how much pressure or how quickly or how slowly they are supposed to insufflate the abdomen with the oxygen. Now, once the surgery is done, then comes the part of the post-operative pain management. Now, in case of laparoscopy, as we all know that in the first 24 hours, it is actually more painful than an open cholecystectomy. But after 24 hours, the situation reverses. And that is the time when open cholecystectomy is more painful compared to the laparoscopic surgery. And this is because in the abdomen there is this what is called as the parietal peritoneum and the visceral peritoneum, having its very complex innervation and all those things. So the best type of analgesia for these patients is actually central neuraxial blockade, like an epidural anesthesia. But that is not possible in our case due to the presence of antiplatelets. Also, intrathecal morphine is not possible in our case because of the antiplatelets. So in these particular cases, we have no other choice but either peripheral IV blocks, means peripheral nerve blocks, or things like these are TAP block or the quadratus lumborum block. I am sorry, but I am not an expert in regional anesthesia, and so I will not be able to tell much about that. But whatever peripheral nerve blocks or what is called as the plain blocks, like a TAP block or whatever is helpful for these patients, that should be given, and always supplemented by IV morphine and other analgesics like your IV nowadays paracetamol gives us a very good when it is given in a 6-hourly regime. Okay, so that would be my, and after the case is over, as soon as possible, I would reinitiate these antiplatelet agents.
Would you want to do anything specific, anything special for extubation in these patients?
Anything specific for extubation?
Because see, the general experience is most of the times when the surgery gets over and we are just about to kind of reverse and do things, so the pressure and the heart rate starts soaring up like anything. So do you want to kind of control that?
And one more thing, that preemptive analgesia also sometimes helps, like infiltrating the sites with the bupivacaine. That is also very good because the preemptive analgesia helps these patients a lot. And obviously, because it being a cardiac case, all the other cardiac drugs will be kept ready, and then if at all needed, IV, esmolol, or all these things, they can be added. I have not gone into all these sort of basics of what we call as a patient of ISD for this, like the prevention of pressure, the pressure response, and all that is that is a must. But what is very specific to this case is the management, I think, of the antiplatelet agents, and because of antiplatelet related, what should be your management of the postoperative analgesia. And specifically when they insufflate the abdomen with carbon dioxide, the pressure falls drastically in these patients compared to the general population. So a use of laparolift is a very good idea.
Okay.
Can I make a couple of comments?
Yes, sir.
The Nilesh, well managed. I just wanted to ask 2 questions and a couple of comments I will make. The questions are that if you had known that this patient needs lap cholecystectomy before he had the acute MI, and the patient then goes for PTCA, would you just tell the cardiologist to do just a simple balloon dilatation or the bare metal stent so that the period of the antiplatelet drugs can be curtailed? That is one question. Second question is, do you think evaluation of platelet function using TEG or the VeriFlow now, other devices will be of value? These are the two questions I would like to ask. After that, I'll make a couple of comments.
No, sir. Number one is you said that if we had not had an interval MI, right?
No,
So
no, the
then,
patient was supposed to undergo lab poly, but
yes.
as he was waiting, he had the MI. Then the patient was to undergo PCI. So will you tell
Okay,
the cardiologist to do
so
just the balloon dilatation, and he will come later on for stenting, or you will ask him to put a bare metal stent so that the period of
okay, so the sorry, so
anticoagulation
this
can...
patient has sort of suffered an MI.
No.
No,
As
no,
he
no.
is waiting for the surgery, he suffered an MI.
Yeah, so as it is waiting for surgery, if he has suffered an MI, what I had said in the guidelines, that when this type of a situation comes where we have to choose between the non-cardiac surgery and the revascularization, it should be an interdisciplinary approach, and all the necessary specialists should come into it.
No, in this
So
case,
at
lab
least on
poly may not be
angiography,
exactly a emergency, no? Lab poly may not be
where
exactly emergency, so
yeah,
we will have some time
so
to...
it is. Yeah, okay. So whether balloon dilatation itself only helps, I have no idea. But previously, when bare metal stents were available,
Right.
it was suggested that you use them because there you can interrupt them after 4 weeks. Number
That is,
one, and
yeah, I
number
think,
two, if it is anterior MI, and if the if the sort of your cholecystectomy is really an urgent procedure, and if it is only an LAD, then Lima to LAD as a MICAS would be a better option.
yeah, that is true. That is true. And the how would the platelet function assay before doing the lab choline in a patient who undergone PTCA 3 months ago with a drug-eluting stent?
So platelet assay, as per my reading, has not shown to be of any much help in assessing these patients, because because how the patient will behave once you have stopped the antiplatelets. We are more worried about the chance of stent thrombosis rather than the actual bleeding risk in this particular patient.
No, the point is that some of the patients are non-responders to clopidogrel. So you will come to know whether the platelet function is actually depressed or not if you do the platelet function assay.
No,
That's my... The
so
comment
number
is that
one,
yes.
okay. So, but number one is that if the patient has undergone an MI, then he should not be receiving clopidogrel. Then he has to be receiving. So, what the cardiology guidelines now tell that clopidogrel you can give for chronic stable angina. But if the patient has an acute coronary syndrome, it is either ticagrelor or prasugrel. If the patient's age is more than 70 and weight is less than 60, it is ticagrelor. If it is more, if he's a nice healthy man, age is less than 70 and weight is more than 60, then you can give him prasugrel also.
Yeah. Thank you.
So,
You have answered my question. The other comment I would like to make is that if at all you have to go with the surgery in this patient with the antiplatelet drugs on board, my comment is that platelets to be kept ready and it should not be given prophylactically.
yes.
That's a point which I would like to make.
Yes. So I think would you agree that post-operative take would be a better option in this patient if he bleeds?
Yeah, if the patient bleeds, give platelets because patient may be bleeding because of the platelet dysfunction caused by the antiplatelet agents. But the point I would like to make is that prophylactically we cannot give platelets.
Yes.
Not all patients bleed.
So in the blood management, what I showed, a point of care testing is very important when blood component therapy comes into play.
That's exactly that's why I brought in the question.
Yes, sir.
PEG
Yes,
and
sir.
platelet.
Thank you so much.
Thank you.
Yes, sir. Thank you so much.
Thank you
And
so
I
much.
think we should also, post-operative, we should just plan for monitoring the markers and ECG serially to look for any adverse cardiac event.
Right.
Yeah, thank you, Dr.
that is
Nilesh.
a class 1 indication. That
Yeah.
preoperative troponin and 24 and 48 hours post-op. You are supposed to monitor their tropi or tropti levels.
Yeah. Thank you, Dr. Nilesh. Thank you.
Thank you.
Can we go quickly to the next case? Do we have Dr. Balaji sir here?
Yes.
Yeah, so back to you, sir. This is a 30-year female with severe MR posted for LSCS. Now, this lady is a known case of rheumatic heart disease with mild mitral stenosis and severe mitral regurgitation and mild tricuspid regurgitation. She's now 8.5 months into a pregnancy with pedal edema and worsening general condition. So there is a compelling decision taken by the obstetrician that she will have to do a elective lower segment cesarean section. On arrival to the hospital, her heart rate is 118. She's in sinus rhythm, regular. Blood pressure is 138/76. Saturation is 94% on room air. Respiratory rate, she is slightly tachypnic, 30 to 35 per minute. X-ray could not be done because most of the obstetric setups do not have the facility to do X-ray as far as I understand. The smaller nursing rooms, I believe. The echo, which was recently done, showed dilated left atrium, severe mitral regurgitation, EF of 40%, and dilated LV, mild tricuspid regurgitation. The previous echo about 1 month ago showed the echo of MR was of moderate grade. Her bloods, HB 10.6, platelets 2.24, INR and epididymic coagulation is normal. So now she's come for lower segment cesarean section, sir.
Yes, sir. This is seems that this case patient is already in a failure because her RR is 35, saturation is on lower side, heart rate is on higher side. There is pedal edema, grade 4, dyspnea. All this suggests that patient is in a failure, and now we want to do it at emergency cesarean section. First thing, I would like to do this case at not at nursing home level because the facilities may not be available to deal with intraoperative complications or event. At least it should have a tertiary care center where all the facilities of invasive monitoring as well as ICU backup and intensivist and all they are available. Secondly, I would like to do one important investigation, that is electrolyte. I will send this patient's electrolyte because these patients might suffer arrhythmia during perioperatively. Thirdly, this patient is having a MR with ejection fraction 40%, means this is again overestimation of MR, as I all talked in my my lecture, that MR overestimate the ejection fraction. So ejection fraction may be less than this. So for this patient, I don't think any other options of giving one is controlled GA will be the better option. But before that, I would like to start this patient with invasive monitoring. I will put arterial line and I will put central line to this patient. I will give diuretic dose initially. And if electrolytes are normal or if there is any hypokalemia, then I will try to correct it before starting the case. Then I will induce it, as Dr. Deshpande sir rightly described in this, how to induce a very high risk patient or whatever care one must take during managing such cases in perioperative period, like using cardio stable anesthetic agent, avoiding sudden insult and avoiding fluctuations of hypotension and all those things. And I will keep inotropes ready. And as far as possible, I will try to maintain the hemodynamics in a most stable manner. And I will, of course, I will do repeated ABG to maintain normal internal milieu. And I think controlled general anesthesia is a better option to manage this case with invasive monitoring.
Your choice of inotropes, sir, what would you start with?
Sir, for this, basically, whenever you are managing the MR patient, our basic goal is to maintain the forward flow. and decrease the increase in regurgitation, because suppose there occurs a bradyarrhythmia, then there are high chance that there will be a regurgitation might increase. Similarly, if there is sudden increase in SVR, suddenly blood pressure increase, again regurgitation fraction increases. So even if I wanted to use inotropes or vasopressors, I will use it in a very gradual way, like noradrenaline I will use. And I will, for if there is for cardiac contractility, I will use adrenaline. Noradrenaline, I think will be the good agents to support this patient.
Couple of comments from my side.
Yes, sir.
Shall I do that?
Yes, sir.
Yes.
The first thing we need to clarify is that whether the LSCS is emergency or elective. Suppose the patient is term and non-progressing, are you doing it as elective case or emergency? If it's emergency, probably GS course over. If it is elective, there is a role for central neuroaxial blockade, because in MR patients, reduce the systemic vascular resistance may be therapeutically advantageous. So it should be considered. That is one point I would like to make. And if the chest X-ray was not done, do you think we could do lung ultrasound and see for B lines?
Yes, sir. I think it's a very good idea. If lung ultrasound machine is available, we can do lung ultrasound, and if we have got a time, as you said, if it is we can have 1 or 2 days, 3 days, we can optimize this patient in a better way.
Yeah.
And if the element of failure is decreased, then I think we can think of going for regional, because MR patient usually, as compared to stenotic lesions, MR patient tolerates this regional anesthesia in a better way.
Yeah, exactly.
Yeah,
Yes.
yeah.
Thank you. Thank you for that.
Thank you, sir. Thank you, sir. I think now we'll just try to finish off one more case. We have this Dr. Rahul. Are you here?
Yeah.
Yeah. So we have got the 70-year-old male patient with ISD, known case of ischemic heart disease, stable angina, on medical management. He's come for transurethral resection of prostate, TURP. His complaints obviously being he's got increased frequency and an enlarged prostate on examination by the neurosurgeon. His cardiac history goes back as he's got stable angina with angina on exertion and dyspnea on exertion of class 3 level now. He's had coronary artery disease diagnosed 8 months ago by an angiography. He was advised CABG and PTCA, but he opted for medical management and is proceeded with some kind of alternative therapy. So now he's come to you for an elective procedure. For his functional capacity, he's able to do routine work without any discomfort, but more than usual work, like he's not able to climb more than 2 flights of stairs, and he gets angina on more than unaccustomed work. So on examination at this baseline, he's got a heart rate of 78, blood pressure of 138/70, saturation is good on air. He's on aspirin, clopidogrel, rosuvastatin, and metoprolol. His ECG has been quite stable as compared to the last ECG. There is no fresh change. He's got ST depression, ST segment depression is anterolateral leads. X-ray showing mild cardiomegaly. Echo showing diastolic dysfunction and mild anterobal hypokinesia, EF of 50%. This is the bloods, creatinine slightly high, 1.3, and otherwise his coags are fairly okay. He's for an elective TURP. So how would you go about this now?
Yeah. Hello, Vinay.
Yeah.
I think this patient is in first onset. I would like to do one more investigation, as has been informed in guidelines, that I will like to go for its TROP-I or TROP-T test. because many a times serial ECG also will not be able to pick up the changes which occur during MI in intraoperative or postoperative period. Second thing, I would like to, in the drugs for stabilization, I would like to continue the metoprolol and rosuvastatin. And for aspirin, as per guidelines, it should be discussed with the surgeons. And as per guidelines, the aspirin can be continued, but we have to discontinue the clopidogrel, and it should be the clopidogrel should be discontinued before posting him for surgery. He's as per classification, he's in stage B HA classification, and his RCRI class index would be around 2. So he has got a moderate risk of developing major cardiac events. So another investigation would be to evaluate for electrolyte imbalance. So doing electrolytes is must for this patient. I would like the plan of anesthesia would be maintain his oxygen demand supply ratio, because he is in fairly in a stage of it can get decompensated at because of anesthesia plans, or as well as because of the large fluid shifts which may occur during the resection of prostate surgery. So we should avoid bradycardia and hypotension for this patient, and use of diuretics at the time of doing the case is also important. Long-standing surgery or more large resection can lead to a large fluid fluxes, which should be avoided in this patient. For plan of anesthesia, I would like to go for this patient with either spinal anesthesia, which should be limited up to T10 level, because if the level is high, then again it can cause loss of cardioaccelerator fibers, can cause bradycardia and hypotension, which would be detrimental for this patient. Or giving epidural anesthesia in an incremental doses would be another option. I don't think that general anesthesia would be required for this patient, and ABG would be indicated only if the patient is on verge of failure, or if we like to go for detect for metabolic acidosis in these patients. Monitoring, as everyone had said, the standard 5-lead monitoring is essential. I don't think putting invasive arterial line would be required for this patient, but I would prefer to go for CVP, because because it can sudden rise in CVP can give indirect indication regarding the absorption of fluid, and should avoid the TURP syndrome. Of course, this patient should be done at a center where the critical care backup is available, and I would like to shift this patient in ICU at least for 48 to 72 hours post-operative period for this patient. Regarding these things, I would feel the monitoring for TURP syndrome, even in intraoperative and post-operative period, is also essential.
Okay.
Yeah.
So if you have got the facility, would you choose what kind of monitoring? Like, would you choose an arterial monitor, which would be more helpful? An arterial line blood pressure or a central venous pressure?
Uh,
Which one would really help you in managing this case? Because the CVP,
Actually, CVPs also will not give a very
yeah,
good estimation regarding the fluid status and all, but
yeah,
it would be an indirect estimation. And again, in case of emergency, if we like to go for any inotropic support or something, then definitely the
yeah,
CVP line
access.
would be more handy for such cases.
Okay.
Yeah.
Sir, your comments?
Frankly, I'm happy with the management.
Yeah.
Regional technique is absolutely more, better
Yeah,
because of
right. Thank you, sir.
three or four reasons. One is you can diagnose Turp syndrome, patient is awake.
Yeah.
And if there's a bladder perforation, you can make out by the shoulder pain. And there is evidence to show that reduced bleeding in regional techniques when compared to GA. And because of these reasons, I will err on the side of regional techniques.
Yeah. Thank you, sir.
And I'll have an arterial and CVP lines.
Okay.
It's a stable angina, so I'm able to do it fairly without any problem.
Yeah. Thank you, sir.
Yeah. Thank you, sir. So just a quick thing, Dilip, do we have time?
Sir, time.
Yeah,
Sir,
okay.
you can
So
wait for a few minutes. 5 minutes, sir.
So you can summarize
yeah, what I can
in
do,
few
I can
minutes.
just yeah. So no, do we have time for audience interaction? Like we can have
Yeah, we can give
quick,
5 minutes. Yeah.
Yeah. Do we have any questions from the audience? You can unmute and ask.
Request to ask the questions directly.
Yes.
No, please send in the chat box.
So sir is asking to have a interaction with audience.
Let's see what has come up. See how long do we?
Two questions in chat box.
One question in chat box.
How long
to stop back clopidogrel? See, clopidogrel now, I think the current guidelines say 5 days, as against the initial guidelines of 7 days. Now we are at 5 days of clopidogrel. So we have to stop clopidogrel 5 days before the surgery, for any elective surgery.
Okay, sir. Thank you. Any more questions from the audiences? They can ask directly or they can put the question in chat box.
Yeah, I have a question for Judy. Hello.
Yeah, tell me.
Yes, sir.
Yeah. We had a nice discussion about the cardiac problems, but we missed the point that we have to preoperatively counsel the patient and relatives very nicely. Otherwise, it will be like if there is any untoward event, then there is nothing to look at because we are dealing with so critical patients. And secondly, if we are doing the patients in a cardiac setup, the cardiologist to take the patient to the cath lab, do whatever is required, like do a balloon plasty, do a BAV, do BMV, or patient can be taken to surgery. We should be ready with these kind of things.
Yeah. Sir, Jayati Ghosh has again one question for the clopidogrel. In emergency case, what to do with clopidogrel?
Emergency case has to be treated as per the merit of the emergency. It doesn't matter whether it is clopidogrel or aspirin or prasugrel. If it's an emergency, then we have to straight away proceed with general anesthesia plan. There is hardly any chance of giving any spinal.
Don't talk for 10 minutes. Go there. Don't talk, please.
Dilip, switch off the mic, please.
Yeah.
So
you have to have a platelet arranged. You ask the surgical team to arrange for platelets and go ahead. If the patient bleeds, you have to give platelets. Otherwise, no, that's fine. If there's no bleeding, you're lucky.
Okay, sir. Now there are no more questions in the chat box.
Now there is a just new thing. Not new thing. It has been happening in the last 5 years or so. if there are certain cancer conditions which need surgery and patient has got a multivessel coronary disease, then nowadays people are doing them together.
Exactly.
So
Yes, yes.
yeah,
I agree. Actually, I
so
wanted to say that.
Yeah.
Actually, I
so
wanted to say that.
we had done a patient of aortic valve AVR in a very severe aortic stenosis. We put the valve, gave protamine, and did his TURP after protamine, and he did well.
Yeah,
Then
actually, this is not described in the
yeah,
approach to cardiac patients under non-cardiac surgery.
yes,
We also had a patient with unstable angina with obstructed inguinal hernia.
yeah,
We did CABG and then the hernia was tackled in the same sitting.
yeah, same thing. So we had done CABG and mastectomy because the
Right.
cancer patient can't wait because the staging immediately changes. The
Yes.
patient goes into a next stage. So if you go back criteria, then so we had to use your sort of a. So nowadays it's a discussion. Decision is taken by what is called as a heart team. So heart team has got 3 or 4 people who are members of that: the cardiac surgeon, the cardiac anesthetist, the cardiologist, and the treating physicians.
Yeah.
And then we had to tell and find out what is the best for that patient.
Yes.
So if you feel that this patient requires a fracture or some major surgery of say TKR is to be done, and his aortic stenosis is very, very tight, then sometimes we have to go for a TAVI and do a aortic valve, do a TKR. So such cases are coming up. So that is a sort of a next future of hybrid procedure, we can say, not hybrid procedure, combined procedure, where the general surgery or non-cardiac surgeries are happening along with the cardiac surgeries. As far as the PCI and stenting is concerned, this may not be very possible in those types of surgery where the surgical area can't be compressed. If the area can be compressed, then we can go ahead.
SK sir,
If
this
the surgical area cannot,
is quite prevalent in India, or it is still yet to come in India?
no, it is all major people surgeries are being done at many places. I think Narayana also must be doing this as a routine. Dr. Muralidhar is in charge of both cardiac and non-cardiac, both. He is an overall director. So I think these cases are more challenging and only they are very long cases.
So
For example, we did one case.
Can ask them in institutes
so
also.
We did one case.
To constitute the heart team. At times
we did one case
to take a decision.
Yeah, we did one case where patient had a carcinoma of the cheek and alveolus, and staging was just the nodes were getting positive, and he had a severe underlying coronary disease. So we did his bypass surgery, and immediately the cancer surgeon they took over. They did his hemimandibulectomy. Plastic surgery surgeon took over and did a grafting. So such things are coming up, and they remain give the best chances patient depending on the merits of each case. Thank you.
I have one published case of TAPVC followed by volvulus.
Okay.
So we did a neonate with TAPVC. We operated, and when the chest was closed, we operated on the volvulus.
Yeah.
Vinay sir, there are no questions in the chat box now.
Yeah.
Will you like to
We'll summarize.
Okay, sir.
I think the listeners are tired of hearing us.
No, sir.
This is excellent discussion. To summarize briefly, if I may, what these cardiac cases tell us and have taught us over the years is the most important thing is very good preoperative assessment, whether it's an elective case or an emergency case. The preoperative assessment is the key to a successful management and a successful discharge of the patient from the hospital. So what we do in the preoperative assessment is look at the NYHA status and the METs. Once we have a fair idea of what is this, then obviously we can plan our investigations and everything. Now, also we have to look at, which has been extensively discussed, is the cardiac condition amenable to optimization medically or interventions. Once we know this thing, that what can be corrected and what cannot, then accordingly steps have to be taken. How urgent is the cardiac surgery? Non-cardiac surgery. Then, as has been alluded to in all the talks, by all the faculty panelists, is the setup and the team capable of handling the issues of the patient perioperatively? Intraoperatively, you need an echo to be done. In postoperatively, you need an echo to be done. You need to have an echo machine. You need to have an ICU. You need to have people capable of doing echoes. So that is where the role of anesthesiologist learning echo in today's era is very important. So we have to ensure that everyone, some member of this team should be capable of doing this thing for the patient and solve the problem. So is the setup capable? So that is something which we have to see. And finally, once we have got everything in this, what Srikanth was alluding to is we have to calculate the risk and counseling. Most important is counseling. And there has to be a team counseling with the family, team counseling within the team, with the family, and then it has to be documented. So this is how probably we should now change over our practice in institutes as well as in private practice. That is where many of us still have to gear our teams up in the standardized way. And after all this being done, we have to look at optimizing the post-operative management, because it's not only pre-operative assessment and intraoperative management, but post-operative management also plays an important role in having a successful outcome. So finally, I thank you, all team ISA, NCB, Maharashtra State ISA SAMS team, and all our esteemed faculty. Muralidhar sir, you are an institute in itself. You have been teaching us so for so many years. We are blessed to have you. And I thank Dr. S.K. Deshpande sir, Dr. Rahul Pingle from Akola, Dr. Srikanth from Nagpur, Dr. Balaji, and Dr. Nilesh from Pune. I'm sorry, Dr. Sandeep couldn't join, but we actually wished that he would help us with a lot of interesting blocks as an option for all this perioperative management of these cases. So thank you, everyone, and thank you, audience. Over to Dr. Dilip.
Dr. Dilip, just a minute. I just appeal to all the members of Maharashtra to participate in the workshop which will be conducted on 8th of February at Nagpur 2024 during the ACTACON, that is Indian Association of Cardiovascular Thoracic Anesthesiologists National Conference. And we have got excellent international and very experienced senior national faculties. And we have got dedicated workshop for transthoracic echocardiography. Those who are interested in learning that, please join. There are excellent faculties for that. And also, there's a workshop on focus. So as everybody, especially Balaji, has highlighted the importance of focus. So it's a wonderful faculty, and I think you should take the advantage of that. So I welcome you all and appeal to you to please register for because these two workshops would be for the non-cardiac anesthesiologists, I think.
Sir, we have hemodynamic also.
Focus.
We have got
hemodynamics. Yeah, sorry. Thank you, Vinay.
We have got hemodynamics, we have got transthoracic, and we have got focus. So all these three workshops will be of real interest and boost to our young anesthesiologists from all the institutes as well as private practitioners.
And the course teachers are very strict about it, and they said that the number should not be too much, otherwise the quality will decrease. So don't waste too much of time and price. Thank you very much.
Okay, now Dr.
Thank
you. Thanks.
Thank you, sir. A very good evening to dear members, esteemed speakers, and my participants. I extend my heartfelt gratitude for your active engagement in today's academic session. Your insightful contribution have enriched understanding of the subject. Very special thanks to our distinguished speakers of today's webinar, Dr. Balaji Asegaonkar sir, President SAMS, Dr. Nilesh Juvekar sir, Dr. Kanchi Muralidhar sir, Dr. Srikanth, Sri Krishna Deshpande sir, Dr. Sandeep Diwan sir, he was not able to join us, Dr. Srikanth Bobre sir, Dr. Rahul Pingle sir, for sharing their expertise with us. And it was a really academic feast for all of us for such high-risk cases. Thank you so much to our speakers. Special thanks to our today's coordinator, Dr. Vishali Ankarwar, and our moderator, Dr. Vinay Kulkarni sir, for the flawless conduct of the webinar. Also, we are thankful to SAMS for giving us this platform, to ISNCB for organizing this webinar. Thank you so much. Good night.
Thank you.
Good night, everyone. Now we all can leave the meeting. Thank you, everyone, again. Thank you.
Thank you.
Thank you so much. Thank you so much to all these speakers. Thank you so much.
Hello. Hello.
Hello. Yes.
sir, end
Ganesh?
झाली ना meeting.
Okay, okay. Yes, thank you. We'll end the meeting. Thank you.
Okay, okay.
Recording stop
Thank
करते
you,
जरा.
Ganesh.
Oh,
Yes.
please stop the recording.
Okay.
Thank you, Ganesh.
Welcome, sir.
Dilip, can you see how many participants are left till now?
15 participants still there.
Okay, okay. I'm not able to see the participants.
दिलीप स्क्रीनशॉट लिया